So, good morning, everyone. I'm Ruturaj. I take immense pleasure in welcoming everyone at the Center for Cellular and Molecular Platforms, that's CCAMP. We foster deep science research and innovations for societal impact, and AMR is one such area. Welcome. Thank you. As I was just starting, I welcome you again to Center for Cellular and Molecular Platforms. We are all here. We are all researchers in the field of AMR, innovators in the field of AMR, and we take immense pleasure in organizing this event along with Innovate UK as Vicky. Thank you for the background help and the foreground help. I insist that everyone please make use of this program. Please share ideas. Please talk to each other, talk to us, and hope this day leads to your innovations, progressing to the next level. With this, I request Dr. Taslim Alif Sayed, the Director CEO of CCAM, to to talk about the various activities that CCAM does. AMR, of course, apart from AMR, we focus on different areas as well. This goes from deployment to early stage and also funding. So quite a few different activities and different focus areas. So I please request Dr. Taslim to come up and talk about CCAMP. Thank you.
Thank you. Thank you, good morning, everyone, and warm welcome.
Do we have to record the video from mic?
They are not giving me the mic.
Just stop it.
Yes. No, I'm just kidding.
Yeah.
Sorry for that. Sir.
No. Sorry, I was just letting them set up. Okay. So, good morning, everyone. It's an absolute delight to welcome you all the invitees. First of all, a big welcome to the entire UK delegation led by Phil and Anurag, who are here. Great to have you back here. It is almost a year, if I'm not wrong, since you were here.
6 months.
Less than that, so we are getting better. Yeah. So it's great to have you here, and I'm sure there are reasons that we are coming together. Phil and I, we got to meet at least twice in between the year as well. So that's great engagements which are being built up. And the reasons that we are actually having this workshop and we are meeting and bumping up is that there is an imperative, quite essential, unnegotiable, non-negotiable necessity in a way that we got to work together between India and UK for AMR innovations. That is absolutely, it's right that we got to do it. And I think the delegation today and other reasons that we are discussing in other ways as well, we're about to possibly next year, we hope that we will have one more year, but we'll have major announcements by the year that you come back next year. And that's, we are hoping one next month, by the way. We'll let it happen and then announce rather than not in taking it out now. But we are hoping even major, other than that, a major announcement by the next year that the UK delegation comes in because two reasons. And I'll go back to CCAMP, but because two reasons. AMR, without a doubt, is the biggest issue of global health. We all know about it. I don't think I need to justify that to this audience. Second, UK is one of the first mover in terms of AMR. We all know about it. The efforts that they have done for years in terms of research, in terms of seeking innovations through multiple vehicles. Of course, Innovate UK is one, and then there have been several others that we all know about, including recently announced Trinity Challenge, where Dame Sally Davies was involved and leading it. Before that, she was involved in Longitude Prize, and I had an opportunity to be invited by her at the Royal Society last month for the global AMR meet, where she got who was who of AMR, in the room with Prince Williams there as well. So that was really fantastic to see last month in London how they are committed, where ministers came and committed very large amounts of funding and investments for AMR and innovations at large. So that is their very important thing from the UK perspective. At the same time, we all know that the AMR numbers that are being projected are in a way an underestimation. We all know that. The numbers are pretty larger than what we all know because most of the AMR deaths are never reported as AMR deaths. We do know that, and the many countries are highly vulnerable to be even growing those numbers. And India is definitely one of them, where India is highly vulnerable in AMR, and India is also moving fast in AMR and building innovations and so on. So that is even a major thing where we got to make sure that two countries come together, and the innovators and researchers who are in those countries come together and start building innovations. And we will see some during the second half of the day, we will see that thing. So we are very excited to have the delegation here. We are very excited to have local leadership, including from the Department of ITBT, Ms. Perninga, who is championing some of the major efforts in the new role that she has now in terms of building healthcare innovations, building agri innovations from here, and catapulting it to the global collaborations that are happening in multiple countries. So we are very excited that she is here, so she can possibly guide us in terms of what we can do better at the same time. And then we have a very active partner for us, that is UK Consulate here, the High Commission, who has been working with CCAM for now 15 years, and CCAM is only 15 years old. So it has been almost from the first day UK High Commission has been working. We had a great opportunities through UK High Commission to always work at the very high level with the Science and Innovation Minister and other ministers who had the opportunity to meet in Bangalore and present what we are doing. So it's a great synergy that is there, and of course then the real content. All of you who are the innovators and shakers or movers who are actually here and taking the effort further. So with that longish and not quick preamble, I thought it was very important to actually get to the context and why we are here. It's the reason that we are excited about is that today we will actually possibly take one more step, and possibly just long or large step, whichever way you want to put it, towards building those collaborations to address or bend the curve of AMR, as one calls it. And we are very excited that we are we are putting that effort, and we are hoping that we can follow up on that effort as we are continuing our dialogue with Innovate UK as we go forward. So with that long context, I thought that I'll just also quickly tell you what CCAM does, which would be not only AMR but in broad sense, so that because ecosystem is never a narrow path. Ecosystem is a broad path where different stakeholders come together, millions of people who actually enable it from different angles, which are not always known or visible, but are intangible in nature, and something that we would like to see. So CCAM is attempting to, and possibly has built in some manner, build that ecosystem where one lands here, you get to connect with multiple players and take your stage to the next level. And that's what we are hoping to build today. Okay, so I'll not go very detailed about CCAM, but I'll try to see what we can do. So to begin with, CCAM was set up in 2009, as I said, 15 years back, with the support of the Department of Biotechnology, Government of India, to be an enabler of high-end research and innovation in life sciences. Again, adjectives, I'll try to see what we got to do by that. So when they proposed the model, it was a quite a bold model, because at that time, government was largely supporting pure play academic research, which is basic research organizations. So when they put that up, so we, in the hindsight, few years, we saw the role as one calls it, and a simple analogy would be to kind of on a soccer field, the midfield player, the midfielder, who actually works with both the defenders and strikers. Defenders analogy being the basic research scientist who build the early movement of science. The catalyst supports the movement of science to the next level, and strikers, the industry and startups, actually take it to the next level. So it's a very midfield role, which is sometimes, are not best known to scoring goals, but to make the movements when the score is done. And that is what we take pride, and that is actually the reason that if we stay true with that analogy or that thought process, one of the reasons of a small success we have is that we stayed true to that. We didn't try to be either that, or we did try to be the other then. We knew what we wanted to do, because actually it was an open field. Nobody was there. So we got best of the opportunities to go and make it count. And we are actually growing up. We are growing significantly last 5 years. We have a national play, as we know, at multiple stages. CCAM leads India's largest effort in AMR called India AMR Innovation Hub, which I'll talk to you about in a bit as well. So it's a significant play that has happened because of that clear role and responsibility given by the DBT to CCAM at that time. But important is that CCAM actually grew phenomenally because of the larger ecosystem that it has been a part of. That is the Bangalore Life Science Cluster, which is India's largest life science campus, which is around 40 acres in capacity, almost 2,000 people, all of them linked with life sciences. So by the scale, and if I may also say by the state of excellence in terms of research and innovation, it is by far the largest. It has a huge margins over the next in India anywhere else, and we would like to continue to grow it, and the power comes from the excellence of individual organizations. I'll quickly tell you from bottom up in a way. NCBS is a center of National Center for Biological Sciences, a center of TIFR, by far one of the best institution in India for biological science research, by far, if you actually go by real research on, in terms of that. TIGS is a recently funded institution by Tata Trust for around $70 million, largely for building tools, genetic tools for health, agriculture, and environment. And again, it's doing very well in terms of what it has. InSTEM is India's only federally funded stem cell institute. Again, has been doing phenomenal work in basic biology and regenerative medicine. And then CCAM is very, very niche midfield player of technology and innovation, as I call it, including translation research. So this has really become a milieu slowly and steadily where all four of them are independent. But if you get a chance to take a tour today, you will see that we are absolutely intertwined in each other in terms of the expertise, the technology resources, and other things. So it's really a fantastic milieu, and that is helping innovators a lot, because when you're in an environment which flourishes your ideas to the next level, that's what actually takes you to the fantastic work. So what we have is probably, I just quickly go through it. We have three verticals here. One is high-end technology platforms, which facilitates research. Second is research translation program, which develops technologies. And third is nurturing innovation. So what is the high-end technology platforms? We all know about possibly the core facilities that we know, but India has many, many research institutions, but not all of them are at the same level of availability of high-end technology infrastructures. Some of them are highly privileged, some of them are not so privileged. So there is an inequity in terms of that allows researchers to actually be affected by availability of high resources infrastructure. Like possibly institutions are there which would not have a confocal microscope. As simple as one confocal. And this campus we have 12 confocal microscopes to begin with. There are institutes which would not have a mass spec. We have 15 or 10 confocal mass spectrometers here. So what would happen to talented researchers in industry, in startups, in academia, when they don't have it on daily basis? Their growth, their research actually gets stagnated. So how about making it open and letting them get used by whatever is it? So we have actually put all our technology platform on this campus across 4 institutes together for last 15 years, and let it be available for anybody from country and even outside. We have users from UK as well, by the way. But coming back, and those has been really important, because this way a young researcher, even an older researcher, doesn't matter, doesn't have to now wait 2 years to write a grant, get an equipment, and get the work going. They come, they land, they start a lab, and the next month they can have an experiment done here if they need to be. And that is very important, because that comes with a highly capable expert here. What has happened with that? Very quickly, as you can see, these technology platforms are now used by researchers, academia, industry across India. It is not only local. And this is only on this 35 acres space. Capability has been used across India, which is, hundreds or thousands of acres or even more. I can't put the number on it. And that is the enabling role that we have played through this vertical, where more than 4,000 projects have been done, which would not have possible if this was not there. Almost 2,000 researchers have been trained hands-on on this. More than 450 organizations have continuously used it one after another, and of course many nearly 250. This is an older slide. 250 publications have come. So this is a summary of the first vertical, And we continue to we support Trinity College, we have supported Imperial College, and many other colleges for the research through the platforms that we have here. They can do it. We support UCSF, we support many other international NUS or National University of Singapore and many others. They have been able to come and use this. Without putting new investments, we have just taken the extra capacity on the instruments which are available and made it accessible to researchers across. So this is actually playing a multiple role in terms of the loop that is actually coming back. So you are more than welcome to use it as you need to do. Quickly, I'll go to the next one. That is a research translation vertical. I'm sure you all know that academics do phenomenal job in going after a new understanding of biology, uncovering the new facets of biology as they put their time on it. But many times in many geographies, and including India, most of these actually amazing discoveries get stagnated at TRL 2-3 level, because good discovery has happened and good publication has happened, but doesn't go further. Although the academic may wants to take it out, but industry says, I actually love the science that you have done, but it is far away from where I can take it. It is actually still far, far away. Unless you do A, B, C, D, E, I will not be able to take it. You have to de-risk the science, you have to validate the science, you have to convert into industry-ready technology. And that is the larger effort we have taken here, where we go around and have a national call, where we say that academics who have amazing science out, can you put it out? And we will then look at its translation potential, talk to industry, understand what is required, and do the translation part. Now, this particular work has now, I'll give you a quick round about that. This particular round has now been funded by the highest office in India in science, which is Principal Scientific Advisor's Office. So they have funded this program. We are calling it Translation Accelerator, and it has been around now for 8 years, and it has also been co-funded by philanthropic support from one of the Infosys co-founder, Chris Gopalakrishnan's philanthropic trust called Pratiksha Trust. Very happy to share that out of 9 to 10 projects that we have taken out of academic gems, which were possibly still not gone further, we've been able to convert 4 into a tech transfer and 1 into a spin-off. One of the spin-off is actually here, Rapidex, which is technology for AMR, AST, and other things. So Rapidex technology is right here, which is actually an extension of amazing work that was done by academia. We worked on it, made it ready for next stage, and that has been taken forward. So that one of the work we have done in sepsis as well. I'll just close by that. We all know that there is no cure for sepsis. We have taken one of the work in sepsis and now actually transferred it to a Dutch pharma biotech. So it has been a work that we have done over time that has actually now this discoveries have been translated and given to international partners to take forward, and we are very excited that we are doing. So this is a second way of enabling high-end deep science research and innovation that we have attempted and gotten somewhere. It's almost a minefield to do translation in India, and in general, as you know, it's a binary thing. Either it works, it doesn't work. It doesn't even give you a publication because you are just validating it. So to work in a minefield and still get somewhere, we are happy that we can do better, but at least we are happy that some of them have come through, and we are excited that with collaborations like this, we can do better. So that is the second vertical, friends, that I wanted to talk about. Third vertical is about entrepreneurship and innovation, which has very large view of it. And we have the ability to support at different levels, from early stage innovations, we have funding programs. So we have been able to collaborate with different funding agencies of India and the locally very active kind of government of Karnataka as well, and build several innovation capabilities here, which eventually gives us a capability of funding almost 12 to 13 funding schemes. So we can actually fund you at the almost at the pre-idea level, which is called immersion. You don't have an idea what you are trying to do. So it begins with immersion. It goes with pre-incubation, where you're not yet formed a company. We can fund you at the formation of the company level or individual level as well. We don't need to wait for you to do it. Then we can fund you at the seed level. We can fund you at the proof of concept level. We can fund you at the post proof of concept level as well. And the reason we want to build it, because I think amazing deep science cannot be done without funding, and you need ability to fund you constantly and give you that support. And that is really, really good in a way. So, and what has happened is that possibly the slides are a bit older than I would have seen, but across these years, now we have funded nearly 400 companies and supported nearly 2,000 biotech companies in India. That is good, solid cohort now. That's a good, solid work we have done across India. Out of those 400, we have funded, and because we are funding idea level, small, we have funded around $12 million to $13 million now. They have gone ahead and raised nearly $500 million at the valuation of $1.2 billion. And that is very exciting for us now, that there is now a validation from market that what we have funded in science at the early stage, there is a kind of a market validation that somebody else is putting money to, and also thinking that they will get the money back. And that is a very solid, that's one of the first times such a story has happened in Indian biotech history, that such returns are being seen. Ourselves, where we have actually put equity, we are seeing good results by some of them, because once you go and spend some time, they are getting amazing returns overall. So that's a larger effort again across India. And we have built capability across different themes. As Rituraj mentioned, AMR is definitely one of the consolidated theme we have, but we have efforts in molecular technologies, regenerative medicine, infectious diseases, oncology, maternal child health, each one of them, I just wanted to repeat, each one of them we have possibly 5 to 6 products which are ready, regulatory approved, or in total around 15 to 20 innovations happening. And that is real. Now we are talking, because innovations or solutions cannot be done by one solution effort. It has to be multiple efforts in some zone, and some of them will be successful and some of them will not be. And this is growing every year, by the way, just to tell you, we are investing in nearly 50 to 60 companies every year, CCamp. And that is really a good number. We got to keep on doing to make a kind of critical mass of innovations and solutions which are coming out of here, and then handhold them and connect them with you, and see how collectively we can take those innovations to the next level. It includes, of course, Agri. It includes many other efforts. Agri is specifically a specific center of excellence in that we have, which has been supported by Government of Karnataka, both Department of ITBT and Department of Agriculture. So AMR, we all know the problem. I'll not go into this. You know this as well very clearly. As you can see the colors, and you can see at the bottom, unfortunately, the global south is the most vulnerable. But we all know that it is not going to be only affecting global south. So it's a global fight. We need to solve it together. So globally, we don't have such an impact in a way. So what is needed? What we want to do is to ensure that we can build those innovations which are contributing towards that. We want to build innovations locally so that we can solve the problems locally, and those solutions can be eventually interesting enough to be done in collaboration with global best, and also could be possibly useful for global north as well. And that's the play, that's the vision that we need to have. How do we build a global collaborations for global south, and how do we take global south innovations for global north as well, because that's how it has to be. The thought possibly that I would like to say that always that only innovations coming from global north will trickle down after 5-10 years of its existence and solve global south problems. It's not working, because the global south context, the local limitations are different from global north, and it is not going to solve 100% that, and hence it has to be a combined collective effort of global north and global south jointly building innovations and solving those. And I think otherwise the last mile will keep open, because the global north most sophisticated, most complex innovations are not going to work in resource limitation settings in global south. They are not working. I can go up over coffee, I'll give examples, but they are not working. We are seeing in the last 15 years, and that's why we are even more confident about our philosophy of building local innovations and then working with global north to solve it together. So where are we attempting to build those? We have a prevention capabilities, screening capabilities, diagnostics, including companion diagnostic, therapeutics, antibiotics, stewardship, and AMR surveillance. That's where broadly we are looking at in terms of what we want to do. Of course, we are building larger effort. We already have, by the way, in AMR, we already have 50 to 60 innovations. If I'm not wrong, today, how many are present today?
16.
16 are present, which are largely from Bangalore. You can imagine many of them could not travel because India is much vast country for them to travel. But there many are not there, but they are in your list for you to read and connect if you need to. They are there already. So you can imagine we already have 50 to 60 innovations in AMR already, but we are still believe that this is not enough for solving problems, and we want to do more towards that. We are working with, as one would call it, we are working with the central government of India. We are about to be a major part of government of India's next National Action Plan 2.0 on AMR. NAP, we all know. NAP, UK NAP has come a month ago, if I'm not wrong. India's NAP is coming in a month's time, hopefully. Draft is ready. And CCAM is positioned as an innovation engine of NAP. That's great positioning, according to me, where will work with all the ministries and attempt to support with innovations now, addressing the AMR per se. So we are delighted, and it's possibly because of the work that we have done over the last 10 years in AMR, which has taken us to this positioning, and hopefully we'll be able to do it. For that, we are actually raising funds. We are more or less putting together, not necessarily under that name, but a dedicated fund for AMR, which is not an equity fund or it is not a private fund, a dedicated amount. We are hoping to raise that amount to be around, and happy to see any inputs from anybody, but we are hoping to put together, and for UK numbers these are smaller numbers, but for India it will be a good number, around 15 to 20 million dollars. We already have commitment, semi-commitment for I would say 7 to 8, so we are through half. And this for 5 years, by the way, and we would love to get inputs from you on how we can build it. And that will be a dedicated fund for solving top 8 to 10 problems of AMR in India, prioritized problems. This will not be a random funding. It will be a prioritized problems that we'll have from the ministry, as you can see here. So it is done under the chairmanship of the Office of Principal Scientific Advisor to the PM. And we will build that capability under the umbrella that I mentioned, India AMR Innovation Hub, and we will be able to support funding and pilot validations through that. This is the larger platform that I talked about. There are several global players in it already, which includes the BMGF, the CARBEX, the DNDI, Path, and many others that I can't read right now. But fantastic to have that all of them who are working in India are actually a part of it. So all in all, if I wanted to say that the vision is to prioritize the problems, top 10 problems, and take 5 years and try to see if we can have build innovative solutions which can address India specific problems. But it doesn't need to be, and I want to repeat one point, and I take 30 seconds of your attention. It doesn't need to be India's innovation solving India's problems. So we have an arm which we are calling it as a global arm, international arm of innovations which can solve India's problems, and we'll be able to get you funding for that. There's no point. The idea is not to promote entrepreneurship. Idea is to solve the problem. So we will have problem statements, and we will request your attention to those where you can see, hey, this is closer to what I can do. We are here to get funding for you. We are here to get partners for validation. We're here to ensure that your innovation, if it is best suitable, to get it going and solve problems where we can even prevent some lives, getting lost through the AMR. We will love to do that. So just wanted 30 seconds of attention on that. That there's an international arm, and your input on that will be very, very exciting. I'll not go into it, but again, it is a very wide AMR. We all know as a human AMR, there's an agri-animal AMR, and there is an environmental AMR, and when you put all together, there is a One Health AMR. So it's a very interesting space, and we are all in because we don't think it can be served from one side to another. And for that, we have global collaborations, which includes funding from CARBEX, which is in a way world's largest funding player in CARBEX. We also have collaborations with Netherlands. We have collaborations with Switzerland. We have collaboration with GARDP. All know the faces as well, so I don't want to even say who is who. You will figure it out. And of course, we have now funded from India's top foundations who are coming and funding this, like SBI Foundation at the right bottom. And we are hoping that we'll have a larger collaboration with the UK in coming months or so. Of course, we are delighted to be in top 5 global accelerator networks funded by CARBEX. As you can see, the rest 3 are either in the US or the Western Europe, and we are delighted to be there. So it's great positioning for CCAM to play at that role. And CARBEX has still now funded 3 startups in Asia. And we are very lucky to have all of 3 are from CCAM. So it's a great. We are touched by good luck on many fronts here, and we are delighted. The companies like what you will hear today. A very smart guy called Vasan will be speaking as well later in the day, and so he will be talking about Bugworks, and then we have Gangajan and we have Module also who are being supported by Carbex. So, of course, there is a vision for AMR and NAB 2.0. We are hoping that this gets through. This will be great capability, and there are innovations that you will hear today, see today, in preventing AMR, in diagnostics for AMR, and therapeutics for AMR broadly. I'll not go into those details because they are here. They are in your book. The set that you have gotten. So I do not want to do, but we have a good, solid cohort now, and we are hoping and working with them. We all know AMR as a field and AMR as a market is not easy. So it will require a commitment to keep working with you guys so that we can see that we can do best in terms of outcomes which are there. There are several efforts which are going on in AMR. I'll not go into this, sorry. But just want to stop and say that we are very excited for today. As you can see, we are doing a lot of work with the support of agencies like Government of India, like Government of Karnataka and many other foundations. And our global collaborations, what you saw on the pictures, is enabling us to take the entire effort to the global level, understand where the global stage is, what are the lacking, how we can collaborate and do some of the work. We are hoping that today's meeting, I'm sorry I've taken much longer, but I hope today's meeting is going to be one more step towards together solving the issue of AMR that we all know is a most critical component of global health as we go forward. So thank you so much for joining me, listening to me for a longish stint. But I think I hope the context is set and the players are all set, and the midfielder is going to come out of the play and let the guys go there talking. Thank you so much. Thank you.
Welcome Dr. Phil Packer. I invite him to talk about Innovate UK and the mission of this particular delegation. He's the innovation lead at Innovate UK and works also has expertise in vaccines and is instrumental in developing and delivering funding calls and workshops and strategies. Dr. Phil, over to you.
Thank you. So I'm first of all, I'd like to thank Taslim and everybody here for inviting us today. Great talk. Put everything in context. It stopped me having to. I'll try and keep myself relatively short. And lots of familiar faces for me as well from when I came last time. And if I've forgotten people's names, I do apologise because I meet so many people when I've been over here. Oh, can you hear me? Oh, can I use? I'm going to wander around because is it on?
Yeah, just switch it on.
Put my glasses on, which might help. Right. Okay. Thanks, Taslim. And I think it's an interesting point about greater collaboration. I'll come on to that in the future. And you've been very kind about the UK leading, but India are also doing that. And I think you can recognise that by the fact that you were in the meeting with Dame Sally last month, and we also had representation, obviously, on the Longitude Prize from India. So we recognise the importance of India as a collaborator. And I think we recognise we're working to a similar aim, and we've got similar ideas, and we're so similar that in fact there's two companies in this room with the same name nearly, which I think we just need to clarify that so everybody knows. So we have a Rapid DX in India, and we've got a company with us called Rapid X in India and Rapid DX in with us. I'll put it round right. God, get it right. So I'm confused. So anyway, so there are two companies with nearly the same name here. So we're all trying to do the same thing. We need even giving ourselves the same name. So make sure we don't confuse each other when you're talking about Rapid X and Rapid DX. Anyway, I'll stop from that point.
You can call Rapid India and Rapid UK.
Yeah, I was just going to do that. You have a bio at the end. Right, okay, there we go. So I'm going to talk a little bit. I'm not going to go into great detail. I'm going to talk a little bit about UK strategy with the new AMR strategy and a bit about what we're doing in response. But just to put in context, Innovate UK is the innovation arm of the UK government, and we're given funds from the UK government to basically to develop businesses with the aim to build them and to grow their capabilities and therefore to help our UK economy. So that is our main aim. I'm not going to go into great detail, and we do that in a number of ways. by direct funding, by providing support and workshops, by organising things like this to try and build collaborations, and various other things. And this is an output of our programme. This is called a GBIT, where we bring companies to an area where we know there's a real similarity in operation and strategy, and to try and build collaborations. And that's basically what some of the roles that Innovate UK have. I'm conscious of time, so I'm not going to talk for too long. So I'm not going to, you put the context of AMR in place already. So we have really been involved in AMR for quite a long time, and Taslim's mentioned that. And we sort of prioritise that, and we've had a 20-year vision, and we've had a national action plan, and the first 5 years of which has just ended. And we've got a new action plan, which I'm going to briefly give some points to now, just so you can see where we're going in the UK. And this is quite high level, but I think it is worth just highlighting some of the things that have come out of that, and you can see them on the slide, which I think are quite important, some of them nationally, some of them internationally. So I think reducing exposure is an important thing in humans, and I think the other one thing I think is particularly important, and we do often forget the One Health approach in AMR, so I'm going to highlight this one down here, which I think we've done a great amount of work in reducing AMR, antimicrobials use in farming in the UK, which is really important. The other thing I think is very important is the pilot program for helping support the development of new antimicrobials in the UK, which other countries are now trying to do something similar. And without that, the development of new antimicrobials is always going to be a problem because there's no market. So that is working well. We've had two new antimicrobials involved in that pilot scheme, and now the scheme will carry on. So essentially that means that we are providing companies with funding for their antimicrobials, even if they don't sell them. And it's known as the Netflix model quite often. So essentially, the company is given, say, £10 million, regardless if those antibiotics are used or not, because we know that if you have a new antibiotic, the chances of it being used are low, because we don't want to cause resistance to a new antibiotic straight away. So, there's not a good model, and this will help it. So that's some of the high points from the last plan. So I think some of these principles you would think are pretty obvious. Taking a One Health approach, we sort of mentioned already. Making sure we collaborate across the UK, and I think that also means globally as well. Reducing inequalities, and there's also resilience to a changing threat landscape. So those are our 5 principles. And I'm not going to go through these in great detail, but you can see the 9 strategic outcomes that we're looking for. And I'm going to guess these will be very similar to what comes out in the next action plan in India. But I think, obviously for us, we are in the innovation and influence area. But innovation doesn't just sit there. It does fit in other areas. You have to have innovation here. You have to have innovations in surveillance. So we're important right across the area. So those are the main strategic outcomes here. And then there's another diagram here showing some of our research priorities. And again, you can see there's innovation is very important here. And but I think one of the things I always bang on about, and I'm glad to see this, is there's something that we've really got to look at, and it's the cost of AMR. We often don't think about this properly, and the cost of AMR is hugely complex, and we need to understand that. So for example, we keep talking about, there's quite a few diagnostics companies here. Diagnostics has got to be really cheap to be used, but we forget that if that diagnostic prevents us using an antimicrobial, tells us what antimicrobial you can use really quickly, it prevents a huge cost down the rest of the clinical pathway, and that is sometimes lost. So I think fully understanding the costs are really important. So and you can see the other things across there, which I think are probably very sensible. And obviously we have an international setting on there, which is important for us as well. So we have this action plan, and essentially what that means is that different organisations in the UK then go away and try and develop solutions to that. And Innovate is one of those organisations. You have the Department of Health, lots of other organisations set up programmes to try and help that. So I've just put some figures here of what Innovate UK have funded in the last period, really, and a bit before in AMR. And this has been done without any direct AMR funding. So to date, until very recently, we've not had specific AMR calls. We have an open call called SMART and a thing called the biomedical catalyst, where people can put in proposals. So in the biomedical catalyst, it's only for health proposals. So the AMR comes in against all other proposals in health, and in the SMART against anything, including batteries, aeroplanes, or whatever. So we've still managed to fund quite a lot of work and quite within that program without any direct funding. But recently, we've launched a program called PACE. Now, a lot of people have heard me talk about this, and I apologise, and I can ramble on for hours, so I'm going to try and keep this succinct, but ask me any questions later on. So this is a program. It's a £30 million program, essentially mainly over 3 years, but the main funding will be over 3 years, but there'll be 2 years as the project's complete. And it's an initiative that will essentially try and fund the midfield. It's to try and help the development, an early stage development of new antimicrobials and diagnostics in the pipeline. And the aim of this program is not just to give money to companies to go away and do things, it is to provide a wraparound support. So it's a little bit about like what CCAMP do, where we will provide support, we will embed people into the programs as appropriate, we will get regulatory advice, make sure you use the right companies where you don't know who you want to use. We'll have a team of companies which we can recommend to you use. Don't have to use those if you're already using another company. But so it's providing support for those companies as they move forward. So this program is essentially, it's co-funded by Innovate UK and LifeArc. Now LifeArc, some of you may know, they're a medical research organisation, they're a charity, and they have now got quite a lot of money to support, one of their areas is global health, and they are putting money into this. So we put £15 million in each, and we are working with the Catapult, the Medicines Discovery Catapult, to help deliver this. Now, the first thing I should say why this is different to what we normally do in Innovate UK is there are various things why this is different. One, it's obviously aimed at AMR and it's specific for AMR. But secondly, it's different in that these projects are not just for Innovate UK companies. So Innovate UK traditionally only funds businesses because it's trying to bring the midfield through. But in this program, we are also funding UK academics and international academics and international businesses, SMEs. And the reason for that is because we recognise it's a global problem and you can't do this all on your own. And also because LifeArc have got a particular interest in funding in low middle income countries, and where the problem is going to be strongest. But we know that from COVID, things don't have a border, they move. So we need to look at this globally. So this is where we're aiming. So this is the defence in the analogy. So there's quite a lot of work going on here. And this is where this subscription model is the pull incentives. And we've sort of recognised that there is a bit of a gap between when things come out of academia normally and before they go into the sort of CARB-X type funding. And we need to make sure that these projects are really well or sorted out and in the right state before they can then go on and get larger funding. So what we're trying to do, as I say, to give wraparound support to get these projects in a better place. And we've been speaking to lots of people, and the likes of CARB-X will say to you, or have said to us informally, it'd be great if all projects that came to us were in a really good state, so we could pick them up immediately. So that's what for the UK, what we've been trying to do, and with some of the with international projects, to get them in a better place to go on further. So essentially, we are trying to avoid our midfield playing like the England football midfield at the moment and going sideways and not going anywhere. We're trying to make them go forward, and And that's the idea, really. It's to make sure the projects are in a better state. We're not trying to be rude about the projects. It's just that a lot of these are new companies and a lot of academics are involved, and it is a different process. So that's what we're trying to do. So I'm conscious of time and I'm already waffling on. So here is the a diagram of what we're trying to do: strengthening, enabling, accelerating. So it's a pipeline, developing the pipeline, de-risking, and trying to accelerate these things forward and removing barriers and making sure they're regulatory compliant, etc., etc. So I'm just going to talk a little bit. So we launched in October-ish last year. And when we launched, we get caught up in politics in the UK, so I'm not allowed to talk about any new calls because we've got an election. We launched this a little bit later than we wanted to because the government wanted to be involved in the announcement and then weren't. But anyway, we launched in probably near October in the end. And when we actually launched the first call at the same time, which was a £10 million call for new to accelerate new antimicrobials and new therapeutics at that stage. And that call has now come through, and so we have just now this is where I have to be careful. We have selected 11 projects at about £1 million each, so we've just gone slightly over our remit to take forward. Those will be announced in the future when we can. And they are projects, again, globally and nationally across a number of different modalities, etc. And this call was very, very well supported. We had 171 initial applicants. Some of them were not in scope. We then took those down to about 24 and then finally picked 11. So it's been a very successful, but it does show that there is a lot of interest in this area and there's a lot of good science out there. So that's the first call. Now I can talk about the second call just a little bit. The next call will be in the similar time as the first one, September, October, and it will largely be based on diagnostics. Can't go into great detail what that will be yet. We're still trying to refine the scope. We're nearly there. But that will be, again, open to international and national academics and universities. Now, I know there's a lot going on in India, so one of the reasons we're here is because we want to make sure you're aware of this, and there may be even some collaborations that can come up to support that. Probably, we haven't decided exactly. It will probably be a similar size. 10 million might be a little bit less because we slightly overspent on the first one projects, but we are likely to support not just large £1 million projects this time, but some smaller more feasibility projects as well. So they won't just be a few large projects. There'll be some smaller ones likely as well. So keep your eye open on that. It will be announced probably formally in September. When we can formally announce the call, although we've said it's happening, so I can say again today. And we will try and get lots of information out before the call opens so you can understand the scope. So that is us, really. I'm going to stop there because I think we're due to go on to the next case. But if anybody's got any questions about any of that or pace, just try and grab me during the day. So thanks very much for everybody for coming, and I wish all you have some good networking sessions later on, and we have shown that those work really well in the past, and we hope to continue to do that. And thanks very much for hosting us today.
So as you all know, we are in Bangalore, and Bangalore is arguably the startup capital of India in terms of quality, as arguably the startup capital of India in terms of quality as well as quantity, and it just is not possible with close government support. On these lines, I invite Ms. Pernica. He's a CEO at the Department of ITBT. We enjoy close support at CCAM from the state government and her department as well. So on these lines, I please request her to address the gathering.
Thank you. Yeah, a very good morning to all of you. Yeah, thank you. And a very warm welcome to Bangalore. and we hope to show you the best of what ecosystem we have to offer. And I'll actually keep it short this time. And but on a more serious note, I'm very thankful to both Dr. Tasleem and Dr. Phil for the wonderful presentations. To be very honest, I go back with one key learning from both your talks, and that is how limited there is a huge scope for the government to broaden its perspective on how we're looking at AMR, because we saw through the, at least I saw through the course of your presentations, that there is a lot of work that needs to be done in this space, and especially since it demands a lot of cross-sectoral work, spanning across departments, spanning across verticals. That is something that the government should ideally be facilitating in a big way. So I go back with that learning, and I thank you both for that. More specific to what I need to be talking to you all about is I'll just briefly touch upon one or two key programs that the government has on the innovation front, and more specifically the AMR front. The Department of Electronics ITBT, which is the department that I represent, is essentially the implementing agency for significant policies of the state, such as the biotech policy, the startup policy, IT policy, ESD, MER, and 9 such policies, most relevant to this context being the biotech and the startup policies. What we essentially do under the startup policy is we, as mentioned earlier, inarguably the best and most significant capital for startups and innovation in the country. We sit on close to 17,000 startups, out of which just 1,000 plus alone are belonging to the category of biotech, and out of which a significant number are working in the space of AMR, and you'll get to see a lot of them today as well as tomorrow, I presume. BBC is happening. So at the Banglore Bioinnovation Center. So we from the department try to support these innovation projects, one, through direct funding to the startups themselves, which is what is called as an Elevate funding, where we offer grant funding to startups. And the second model, which has proven to be a lot more efficient and a lot more successful, is the model of having incubators and centers of excellence, one of which is CCAMP. So what we essentially do in a center of excellence is we bring together the government department, we bring together academia, we bring together startups and all the relevant industry stakeholders, all under one roof, so that they actually work closely in close collaboration with each other and try to find solutions for specific sectors. CCAMP particularly hosts the agri-innovation sector for us, say a center of excellence for us. And we look forward to working a lot more closely on the AMR front too. There is one new center of excellence that the state is going to be announcing shortly, which is the MedTech and Health Tech Center of Excellence, or for which AMR is a major mandate. And we're looking at how we can support the innovation in this space a lot more closely. And now to move on to more, there's a lot more that we do on the innovation space, but I'm keeping it very, very short and to the point. And I'd be happy to discuss this with any of you through the break. And more specifically on the AMR front, post the National Action Plan at the Government of India level, the state too released a recent advisory in the month of November 2023, where they spoke of what major regulatory practices need to be adopted by the Drugs Controlling Authority at the state level. While it is more on the how the government's existing mechanism can try to regulate the sale of antibiotics on a larger scale, I think personally that there's a lot more that needs to be done from the government side, both in terms of how we can bring together various other verticals of the departments within the government to actually, so this is more on the sale of antibiotic side, but as we saw in one of your earlier slides, there's so much more that needs to be done on the diagnostics, on the prevention, on the surveillance. So all of that really needs to come together as one entity. And what the department has always done well, and this is something that I would be very proud to say, is that we've always been good at facilitating the right stakeholders to come together, have the right conversations, so much so that the government themselves may not actually be the problem solvers, but the right stakeholders brought together at the right stage at the right time help solve major of the problems and makes the solutions sustainable, in fact. So with that perspective in mind, I think this is a very strategic point at the journey of the state to bring together all the right stakeholders from the AMR space to come together and have conversations. And I request all the key entities such as CCAMP and a lot of the international stakeholders to also be part of this conversation. I'll leave you all with one last initiative that the department has, which is probably of key relevance to all of you. We have something called as a Global Innovation Alliance, under which we closely work with 30 plus countries, and we have ongoing partnerships and MOUs with these countries. I must say that I think just last 2 weeks ago, the state government led a delegation of led by the minister, Honorable Minister for ITBT, who was present in London for the London Tech Week, and followed by a lot of discussions with both Innovate UK as well as Catapult. So there have been some conversations going along more on the generic innovation collaborations, but we'd be happy to explore something more specific to AMR in the context of the Center of Excellence in MedTech and Health Tech that the state is coming out with. So I leave you all with this, and I hope I've been true to my word. I hope that the conversations that happen through the course of today and tomorrow will prove to be fruitful to all of you, and look forward to learning more through the day. Thank you.
For those words. As Dr. Tasleem mentioned, the solutions for AMR can be from any country. The aim is to solve this problem, and the secondary aim is, of course, to promote the innovations. And for that, we, of course, need help from governments. Having said that, I request Dr. Jocelyn Pereira, who is a Senior Trade Advisor, Health and Life Science at the British Deputy High Commission, and Lena Paul, the Senior Investment Advisor at the British Deputy High Commission, to please address the gathering. Thank you.
Welcome everyone to Bangalore. Hope you had a good stint at Hyderabad. My colleague Leena and I are here representing the British Deputy High Commission in Bangalore. We basically have pastoral care for Karnataka as a region. I lead on trade on the healthcare and life sciences front for Karnataka and Kerala. And as the Department for Business and Trade, our primary remit is to support UK businesses to, as Dr. Tasleem said, engage with the ecosystem. So whether that's the incubators, the accelerators, or with other wider businesses, and also to help facilitate your engagement with distributors, diagnostic manufacturers, as well as even large pharma companies. And I'll let Leena introduce what we do on the investment side. Leena?
Hi everybody, so I'm from the Department for International Trade. My role mainly is to promote Indian investment into the UK, so we facilitate expansions into the UK. I work closely on many programs, hand-holding Indian companies to set up in the UK. I focus mainly on the life science sector, so happy to connect with companies who are looking to explore UK as one of the destinations to go global. So yeah, happy to have those conversations with you. Thank you.
Thank you. Thank you.
We're going to have a rapid session of sorts. The idea is to put faces to the names of companies. So what I will do is share the name of the company and the logo, and I will pass these two mics. Please, once all the companies are arranged alphabetically, once you see your company's logo, please stand up and very briefly introduce yourself, the technology you work on, and what you're looking for from this particular event. Thank you.
And how much time per
1 minute. Yes.
space of rapid?
Yes. Yeah. Okay. There's one more mic.
Morning, everyone. 1 minute. 1 minute, one finger prick of blood, 10 biomarkers, answer in 1 minute. That's the plan for the new technology. We can measure 10 things in your blood. So I had an infection in the summer, in the winter rather, and the doctor didn't know what it was. He gave me antibiotics, but he didn't know why. In AMR, we've got to get smarter at doing that, better diagnostics in 1 minute. This is a Sachin Tendulkar, right? Let's do some cricket rather than football, of diagnostics. And I'm here in India to set up Antimicrobial India, to make production work in India, to make the price point work in India, If it works at the right price point in India, it'll work in the NHS. Thanks very much.
Barefoot lighting.
Okay. Hi. Is mine working now?
Yeah.
So I'm Dr. Simon Holland, CEO of Barefoot Lightning. We work in animal health and nutrition. So how we do that, we work through NGOs and other groups on the ground, through their extension network. So we work with paravets, community animal health workers, and we use animations to make it possible for people at the farm site to recognize symptoms. Each animal species, we have over 100 animations, and it makes it easy to collect that data or to point people and help them recognize something that we need them to look for. Then share that information with a vet who can then either diagnose or look for additional sample or testing and move forward from there to a treatment plan. We can also get the outcome of that treatment plan so we can spot problems happening in the fields. So we're interested in low-cost pen-side diagnostics and also integrating these whole systems and trying to push towards One Health as well, where we can create an animal syndromic map, symptom-based map or disease map, and link that to a human disease development map and start to spot new developing zoonoses. Stop there.
Thanks. Thank you.
Good morning, everyone. I'm Praveen Kumar Kaveri, Chief Scientific Officer, Chexel Limited. We are a rapid microbial diagnostic company. We all know that culture test is the conclusive answer for selecting the right antibiotics, but it takes 48 hours to know the answer. We made it to 30 minutes. Our test is a phenotypic test, gives the right to antibiotic selection in 30 minutes. Also, it gives a gram-specific bacterial load. It just involves 2 probes and a single step, and it is quantitative and matching the accuracy of the culture test. We are in India to get collaborations with academicians, hospitals, and also scientific experts to take forward this project in India, like testing with local strains, followed by the clinical trials or feasibility testing. Thank you very much.
Hello, everyone. Shall I face the camera? So yeah, I'm Noah from Cytocom, and we are developing a rapid antimicrobial susceptibility test, and we're mainly focusing on the bloodstream infection market. So we have a technology which we can use to rapidly test and give information to clinicians on the optimal antibiotic we can use to treat a patient, and this will help reduce the overuse of broad spectrum antibiotics, as well as improving the patient outcomes as well. And so we're here in India to hopefully learn more about the clinical landscape in India, and also look at how our technology may be useful for drug manufacturers who are looking for a way to rapidly QC their products before they release them as well. Thank you. Thank you.
Hello, everybody. I'm Doug Roberts. I'm from Aribogen. We're a synthetic biology company that span out of the University of Warwick. Resistance disease is essentially creating new diseases where we don't have any medicines to treat them. Modern science has found it very challenging to find new starting points for diseases, but microbes are fantastic at it. They've evolved complex biosynthetic pathways over millions of years that create complex three-dimensional molecules that bind very specifically to targets. 75% of infectious disease medicine is derived from nature, but this has been done with only 20% of their genome. The majority of the bacterial genome is switched off. Aribogen have developed an engineering platform that allows us to activate the silent part of the biosynthetic pathways, and also then further engineer the strains to create structural derivatives that have improved bioactivities and stabilities. We're looking for companies that have an interest in complex biology, where they're struggling to find starting points, and also companies that are looking for more sustainable, greener syntheses for their molecules, where fermentation may be able to replace complex chemical synthesis to ensure that products can be made affordably to service a global market. Thank you.
Hello, I'm Nathan Cox from Folium Science. At Folium Science, we use in situ, in bacteria, in microbiome CRISPR-Cas activities to modulate these microbiomes, and that's a fancy way of saying that we weaponize probiotics. We use these probiotics to do things such as control pathogens or to modulate the production of noxious gases or greenhouse gases. Our first product focuses on reducing salmonella in poultry. It also increases bird weights. We also have used the technology that we have in vivo to create a in vitro rapid portable lateral flow-based diagnostic biosensor. We're in India because we want to get into the poultry market. There's a lot of chickens here. And we also want to look at how a GM product would be regulated or registered. Thank you.
There we go. Right. Hi, everyone. I'm Sam Whitehouse. I'm CEO of Litox. We have as the name would suggest, a light-activated drug platform. These have been formulated into gels. In the microbial space, we have a gel that goes directly onto the wound. You light it up for 30 seconds or so, and it will kill the bacteria within the wound. You dress it normally, and therefore you lower the burden of infection. The other platform is actually in oncology, looking at oral cancer, which is also very prevalent here in India as well. So we're here to understand the market, find clinical partners, and ultimately, I imagine, if these go well, then we may end up being an Indian-owned company, in all honesty. So thank you very much.
Hello everyone, I'm Marianne Ismail, I'm founder of Microbira. We use artificial intelligence and infrared spectroscopy to deliver diagnostics through the internet. We've validated clinically the top 40 microorganisms in the UK, and we would like to come to India for several reasons. One, to extend our database. Two, to extend our work on resistance factors to distinguish resistant from non-resistant organisms, and also to extend the work we're doing on direct from urine and direct from positive blood samples to get identifications in 20 minutes or less. Thank you.
Sorry. Hello everybody, I'm Will from Phytoceutical, and we've developed a patented nanomicellar delivery platform. Here are some stable prototypes. We're looking at two things. One is actually tissue regeneration and also degrading biofilms and controlling bacteria without the use of antibiotics. We're interested in now moving forward from some of the cellular data work that we've been doing into preclinical, and then addressing how we could maybe move into a medical device kind of clinical category, looking at things like wound recovery, surgical site infections in India and things like that. Thank you.
I thought I'd bring it back to the front. Hi everybody, my name is Ian Miller from Presymptom Health. We're a diagnostics company focused on leveraging the host response to enable early diagnosis of infection and sepsis. We were formed to exploit a large UK study which ran over 12 years and generated over 100,000 samples and aliquots. And the novel feature of that study was it was designed to recruit patients before they got infection or sepsis. So we're able to algorithmically train our signatures and test products at points leading up to the clinical diagnostic event, which allows us to hopefully provide an early diagnostic solution. We're developing a first product to rule out the presence of infection in patients with mimics of infection, and thereby enable the withholding of antimicrobials, hence our presence on this mission. And very interested in finding partners to further develop the technology, but also try and develop it in a form more suitable for a global footprint, especially in the global south. Thank you very much for the opportunity.
Okay, hi guys. I'm Jeff. I'm the co-founder and CEO of Ramonomics. We are a recent spin-out from Oxford University. And we know one of the holy grails of diagnostics is to enable clinicians to avoid using broad-based antibiotics. Currently, we're building a platform based off of Raman spectroscopy discovered here in India, doing both identification of pathogen source as well as antimicrobial susceptibility testing. And the vision really is to accelerate the transformation of a culture gold standard to a culture-free standard. We're here to look for partners in the research and as well as clinical setting, and also to see if we can access clinical isolates. Thank you.
Hi, I'm the other RapidX Bio. So I'm Nipun. I'm co-founder and CEO of RapidX Bio. We're originally a University of Cambridge spin-out. We're able to test for microbial disease in under 10 minutes, thereabouts, where we can find pathogen identity, antimicrobial resistance. We probably do the world's fastest PCR in a prototype at this point for bacterial disease. So it's 10 minutes PCR, gold standard accuracy. We've just been doing some preclinical validation, and I'm here because 80% of prescriptions that are given globally are given without any evidence, just empirical testing. And so the first antibiotic is given within 15 minutes of a person seeking treatment, is prescribed within 15 minutes of a person reaching a healthcare professional. And the test has to be less than that, faster than that. It has to be faster than 15 minutes if you wanted to prevent that first prescription. We want the first prescription to be the last prescription. And that's what we're looking for. And no prescriptions for viruses, of course. Yeah.
I think everyone agrees that if we want to get rid of multi-drug resistant infections, we need new ways to combat them. We need new tools. That means new therapeutics. So at Tabrix, we're taking a very novel approach to controlling infection with small molecules. And we do that by what we call pathogen-targeted immunotherapy. So we've identified factors that many bacteria, including multi-drug resistant TB, for example, many factors that allow the bacteria to hide for a long time in the body, hidden away from the immune system and away from antibiotics. So we target those factors with small molecules in order to enable the immune system to clear the infection more effectively, faster, and safer. And we're here in India, in Bangalore, essentially to ask for collaborators who'd like to test our compound in clinical strains, in bacteria, perhaps explore with us the mechanism of action and see the potential of our technology so that we can bring it to patients as soon as possible. Thank you.
Thank you. Good morning. We've heard today about the importance of infection prevention, and that's what we've been working on at Vitek Microgenics. Essentially, we've managed to reduce hospital-acquired infections in any given hospital setting using a combination of surface coatings and air purification, very simple but very effective engineering solutions. Not only have we done that, we've also managed to do it at such a cost-effective way that it becomes a cost-saving exercise for the hospital, not an expense. Now, that's in the NHS, and of course, things are different here in India. We're here today to try and find further validation for the Indian market, but also to find a business plan and a pricing point that works for the Indian market. Thank you.
Okay, switching over to Indian startups, the rules apply. Similar rules apply.
Good day, all of you. Okay, good day. I am Dr. Jagdish. I represent Adivo Diagnostics. I have my colleague Swati as well here. So we are a company working on, in general, working on imaging solutions for wound assessment. So in particular, our first product, Illuminate, which has been commercialized in India, looks at autofluorescence imaging and machine learning to predict the areas of wounds which have significant bacterial presence, and we also try to classify this into gram types, gram positive and gram negative. Going ahead, we look at building multimodal solutions to try to understand various other wound parameters such as perfusion and so on. And we are here on a more sort of an explorative agenda to identify how we can collaborate with various other people who are here. Thank you.
the central thesis of an AMR company would be to develop an antibiotic, a broad spectrum antibiotic, and I'm very happy to tell that today is kind of auspicious. I don't think I would say very momentous, because only yesterday evening we got the molecule, our lead molecule, BW977, which is a super broad spectrum antibiotic. The publication got accepted in Nature yesterday. So this marks an occasion where in the last 60 years, this is the first molecule to have a super broad spectrum activity from the worst MDR patients, from all types of infection, from lung to kidney to UTI and what have you. So we are in the middle of our phase 1. We have completed the SAD studies, which is standard ascending dose, and then we will go to the multiple ascending dose in coming months. But this is, as I said, climbing a very big mountain, maybe a Mount Everest. This is just the base camp, because after phase 1, you have phase 2, phase 3. This is a long way. But I'm happy to announce that our molecule is there with all its microbiological, toxicological, PK, all properties are within acceptable range for the clinical usage. Probably in the next 5 to 6 years, we will see it in the market. Thank you.
Hi, I'm Dr. Reeti Arora. I'm representing CRISPR Bits here. We're a company using CRISPR technology for both diagnostics and therapeutics. For AMR, we have a diagnostic panel using CRISPR technology, and we've used it to develop an assay for salmonella, as well as for AMR markers, not just for salmonella, for carbapenem resistance, so NDM, OXA, 48-like, KPC, IMP, and VIM. And that's the first product that we're right now testing to try and launch it very soon, hopefully by the end of the year. And essentially, the idea is to look at bloodstream infections and diagnose at the clinician's office using a very quick technology direct from blood with molecular testing and isothermal amplification, followed by the specificity of CRISPR to be able to detect. Here, happy to look at collaboration, synergies, work together, and learn from all of you. Thank you.
Hi everyone, my name is Mayas. I'm from the Foundation for Neglected Disease Research, which is the R, which is missing here, or FNDF for short. So we are a non-profit based in Bangalore, and we focus on small molecule drug discovery for infectious diseases, bacteria, fungal diseases, viral diseases. Our strongest portfolio is in TB and non-tuberculous mycobacteria. We have a small portfolio in diagnostics, which are mostly proof of concepts, infectious diseases. We also have in vitro and in vivo BSL-2 and BSL-3 capabilities, which allows us to help people, like yourselves, in contract research mode. So here we are looking at potential collaborations, or if you need any help with any of your product testings, please do reach out to me. Thank you.
Hello everyone, this is Appaya from Gangajan. We are a company focusing on developing novel antibacterial protein therapeutics. We have two mainstream programs, one for gram-positive, that's Staph aureus, where we have completed phase 2 trial for nasal decolonization of Staph aureus. And also we're getting into bacteremia, Staph aureus bacteremia. And the other program is for gram-negative, specifically Klebsiella pneumoniae, where we are developing a cocktail of three proteins to target bacterial pneumonia, and we are in the lead optimization stage, and this is a Carbix funded program. So I'll be available around, and I'll be happy to discuss if you need any more information. Thank you.
Good morning, everybody. Thank you, CCamp, for inviting us over here. I'm Dr. Mahua. I'm the Director of Medical Affairs for Haystack Analytics. And it was a delight and a pleasure and an honor meeting all of you. Delighted because I see so much of commitment to antimicrobial stewardship in my 18 years with medical science now. What I know is doctors want to know, is it infection? What is causing the infection? Will this antibiotic work? And I see different groups working for the same. Allied to all your thoughts, what Haystack has been able to achieve so far is designing a direct from sample pan-bacterial, pan-fungal, next-generation sequencing-based test with an automated bioinformatic pipeline. It doesn't end here. What makes it interesting is it has been democratized. We have been able to reach out to tier 2 and tier 3 cities in the country because especially in the Indian healthcare scenario, it is so diverse in the way it is delivered. It doesn't work under one umbrella. So democratizing technology becomes very important, increasing the usability of the same. What we are looking out for now is making deep dive into the population far and wide across the country, where we would want to work closely with the initiatives of the government. We want to be the first aid for them, and we want to explore overseas now that we have the C certificate. Definitely UK becomes an option for us. And of course, once we achieve the FDA, we would want to go north. Thank you.
Pleasure to be here. I am Nagasuma Chandra from HealSeek, which is a spin-off at the Indian Institute of Science. I continue to serve as a professor there, and we've been working on AMR and other things for several years, 20 years now. So we have a range of solutions for AMR. One of the products we are looking for, which is translated into, through HealSeek, one of the products we are looking at in an advanced stage is a host response based blood test for monitoring treatment response to tuberculosis, for diagnosing tuberculosis, for treatment response monitoring, and to find the endpoint of that. So this is a host RNA based biomarker, which can be, and we have an RT-PCR based test. And likewise, we also have a blood test for differentiating viral from bacterial infections. Again, it's useful for stewardship. We also have an app which can help for primary health centers, especially in settings here, where resource limited settings, which can help in, helping the physician to whether or not to prescribe antibiotics. So that's an app. It's a health systems app. Basically, it differentiates between viral and bacterial infections. It's also useful. We have a test which is useful in clinical trials for new antibiotics and so on. Because today, the way the clinical trials are conducted, whether it's for a vaccine or whether it is for a new drug, it still has a lot of limitations. You still need a placebo, you still need a control group of a very ancient kind of philosophy. So I think that can be overcome with some of the new technologies. And our approach is based on combining genomics, transcriptomics, quite a lot of transcriptomics we do, other omics, whatever you name it, a lot of data analysis, bioinformatics, AI, and knowledge graphs. So it combines both the domain knowledge from the biology front, whether it's immunology from the host side or whether it's from the pathogen biology, and put them together, and then we come out with optimized biomarkers. We also have a lot of work in my laboratory, which the expertise we bring to HealSeek, on looking at mechanisms of resistance of antibiotics. And I think, again, many people are focused on looking at one mechanism at a time, but then we have shown, and many others have shown as well, that several mechanisms are operative. So if you want to tackle the source at its problem, then you need an understanding of the mechanisms, basically. And again, we've published this. We've got an approach where we tackle the Achilles heel of drug-resistant mycobacteria by giving a combination drugs. Basically, you target the resistance machinery. And that experience we have done with other pathogens as well, including E. coli, uropathogenic E. coli, and escape pathogens of various kinds. And we have the technology. We have more than what we can show, obviously. So we are very open to collaborations, and we are eager to see if anybody is interested in partnering with us, both as a partnership mode as well as in a contract research mode. So we are happy to do that. Yeah. Thank you.
Hi everyone, I'm Dr. Naveen Kumar, the founder and managing director of Imugenics Biosciences. Our main focus is infectious disease and AMR, and under the AMR we have two different things. One is on focus on diagnostics and also alternate therapeutics. In diagnostics, we are working on molecular and phenotypics. Under molecular, we are working on real-time PCR-based panels of AMR and also NGS-based platforms, and also mainly CRISPR diagnostics. And using CRISPR, we achieved, as you said, RapidX 10 minutes. We could able to diagnose the AMR presence or not. And under the phenotypic test, we recently got grant from DST developing a nano sensor. For we achieved less than 2 hours. We could able to say that which are resistant and sensitive. And in case of alternate therapeutics, we are using the integration of CRISPR and phage. We call it as CRISPhage therapy, where we could able to remove the antibiotic markers specifically from the bacteria, and we able to treat simultaneously with antibiotics. Some of them are multi-drugs, so we really achieved it at the laboratory level, but we are still in the initial stage, a long way to go. As like others, we are also here to, collaborate and see any kind of positive collaboration we can get it. And thank you for the CCamp and also always AMR team for the wonderful opportunities. Thank you.
Hello, my name is Tanay Bhatt. I'm the co-founder of Koshki Sciences Private Limited. We are growing right within CCamp. While one method to eradicate AMR is to continuously finding new antibiotics, we were asking a different kind of questions. Why certain population is more prone to get AMR infections? If you think of population or patients undergoing chemotherapy, those who have HIV infections, or as simple as diabetes, you are way more likely to get infections, especially in the hospital settings where you are undergoing any kind of elective surgeries. I'm saying simple as diabetes is because every 1 in 10 individual, adult population is diabetic individual. And the problem is that when these population gets small incisions or the foot ulcers, they continue to grow. And because of the AMR infections, currently the statistics say that every 30 seconds, one lower limb amputation occurs in the world. So we, instead of looking at the pathogen, we looked at the host. Why host is not able to respond to this kind of infection and not able to heal their injuries. So at Koshki, we have identified there are 1 or 2 specific genes which are overexpressed in the diabetic individual and their skin cells not able to help proper healing and eradicate the infection. We have now developed RNAi technology, which is silencing that particular gene and bringing back healthy healing and healthy immune system in these patients. And in this particular forum, we are looking at those who want to understand our therapy in more details, want to collaborate, and want to take this forward in not just India but international markets. Thank you.
Hi, my name is Venkat. I'm the CEO and co-founder of Papyrus Diagnostics. Pleasure to be here. So we are developing a very highly multiplexed ID and AST device. It's a genotypic device that we are developing. Highly multiplexed in the sense we are doing up to 15 pathogens simultaneous detection. To give a context, now people chase after 1, 2, 3 diseases, and we are talking about 15 diseases. What it does is it distributes the cost. We always talk about low-cost diagnostics. The key to low-cost diagnostics is the scalability, and that we do it by through our diagnostic test. It's a paper-based test, and the best part about it is it's very modular. You can integrate with any RT-PCR. So what we are looking forward in future is people will develop RT-PCR tests, and they can just have our device as a module, and they can devise what test it is. And we have a Papyrus MutaCheck Pro, which can detect point mutations, and here we can detect up to 30 mutations. Again, to give a context, the current best available equipments can detect 10. So we are developing this technology. We have validated for tuberculosis, for drug-resistant detection, and the detection of it. And we are looking forward to developing it more. And we are thankful to CCamp. They have invested in us, and they have been supporting our journey throughout. Thanks. Cheers.
Hello, I'm Satish, CEO and co-founder at RapidDX. So we are a spin-out from CCamp. What we have developed is a rapid antimicrobial susceptibility test directly from clinical samples. Currently it is done for urine, and we are expanding it for the blood sample. Here we are here to seek collaborations or partnerships. We are for the companies who are doing rapid identity of pathogens, or those who are doing bacteria versus viral detections. Thank you.
Hi, Nitin Deshpande, Trana Lab, and we develop actually therapeutic for rare disease, and we are here. We came into this room because of the midfielders here, CCamp, AMR, Quest, and LifeArc UK. We have recently got a grant to develop novel antivirals. Our technology is essentially we can take most of any molecule with chemistry permitting, and we can deliver it inside of macrophages. So what our basic technology is macrophage targeting molecules that selectively bind and internalize into macrophages. So using that we can deliver any anti-infective cargo. So antiviral, antibacterial, antifungal, and we have started working recently on developing novel antiviral against dengue by project sponsored by LifeArc. And we would not have got into this if we would not have got into this AMR, because we work on rare disease, and this whether it you gave us that confidence that we could get into this field. So thank you very much, and looking forward our technology needs. We are looking forward to any people who can have testing abilities against all sorts of pathogen, fungus, parasite, because we don't have any BSL2, BSL3 lab, and we are not into microbiology or virology or anything. So we are really looking for, we need collaborations. It's not exploring, we need it. Thank you.
Okay, starting this minute, I have to be nicer to Rutraj, otherwise he's going to keep sending me at the end. Hi, my name is Nitish. India is the largest producer of shrimps in the world, but there's a problem. The problem is of diseases. So in 2021, the government determined that the loss in Indian shrimp aquaculture because of disease is over $1 billion. And in the last 3 years, this problem has only gone from bad to worse. Now the farmer has no other choice but to use antibiotics. Otherwise, it's going to have huge losses. UN FAO recently published a survey where 40% of the ponds were found with MDR-resistant Staph aureus, which is very scary. So what we do at UltraNutri is we grow an insect called black soldier fly, which are enriched with antimicrobial peptides. When the shrimps are fed with these enriched black soldier fly, their immunity significantly goes up, thereby helping them combat these diseases better, making them more disease resistant, and hopefully we can reduce use of antibiotics in aquaculture. Thank you.
Hello everyone, myself Dr. Anupam Datta. I am the co-founder of Revida. This is a drug discovery startup incorporated in the year 2022. So in Revida we are developing a topical biologic to address the skin and soft tissue infections. This product biologic is this biologic acts as an immunostimulant, and it boosts host innate immune system to fight a broad range of microbes. And currently we are in the phase of lead optimization, and hopefully our product will come to market in next 4 to 5 years. Today I am here to connect with potential collaborators and with investors. So that's all. Thank you.
That's the entirety of list. We are just we stuck to time almost. So the next event is we'll step out for a group photo. We'll also take a tea break and then come here back. Sure.
I just have a question to ask.
Okay.
Hello, Dr. Taslim.
Easy question, please.
Yes, it's a very important question I want to ask. In the context of diagnostics for India, to address AMR for rural and urban settings, which test is important, phenotypic or genotypic test?
Okay. I'll
I'll just quickly take the mic over. No, but I think it is being used both. Clearly, I think you saw players who are doing genotypic tests as well, which is definitely quicker because they detect the antigens, the genes specific to AMR. Phenotypic is definite in answer. Genotypic, we all know, is indicative in answer, where you can say that yes, it is there, it's not there. But if you do not have it in literature, then it is not definite in answer. Largely, both are open. It depends on physician what is available based on the circumstances. They may choose for both. I think there is no gold standard per se, but definite is phenotypic that most people prefer eventually.
Phenotype.
Yeah.
All right. So there is already a lot of rapid tests are available, but what is the challenge? Because almost 80 to 90% still culture tests exist in India. What is the challenge in adoption for this test?
Can we take it up over coffee?
Yes,
yeah.
sure. I really want to ask.
So I think let's take it over coffee because it's a longish week. It's a discussion. There is no real gold standards, but I was just giving you. But let's take it over coffee and build on from there. But since I have Mike, I just wanted two things. First of all, it was great to have a quick glimpse of every individual startups which are there. There was two reasons, of course, to get to know quickly who is doing what. The second reason that all of you have a list in a way, if I may say, so rapid dating hour that we are doing in the afternoon. Idea is that, but there are some slots open, right? There are some slots open, and now you got a glimpse of who is doing what. So I would like for you to possibly take till lunch or post lunch and let the team know if you want to fit in the open slots. So do use that. The final list is with you. Where are the open slots for which startup? So please fill in. The dating hour is going to be open in the premises. Hopefully it will not rain, so it will be a fun hour for us to be engaged with and build on that. Second quick point I want to say, I heard a lot of UK companies which I want to do the landing, do understand with clinical support, do the pathogen access, do many other things, market access and all. Since CCamp is doing it for a lot of our own companies, we have those connects. We will not have to reinvent the wheels for you, right? So it is a practice that is running. You should leverage it. So UK companies who want that support, CCamp has those capabilities, and my colleagues who are here, AMR team, they already have that. We will identify how we can work on it and get you access to India-specific pathogens for screening, for validation, for market entry, for pricing points, because those are day-to-day for them. So it's just easy for you to do that. So I just wanted to have those 2 points. I'll hand it back to you. Thank you.
Thanks. So as I was mentioning, let's break for...
Adding to the full house. Welcome.
Yeah. So we were about to step out for a group photo, and so we'll have discussions over coffee. Welcome, sir.
You're from Malbio.
Of course.
Let him introduce.
Yes,
as
yes,
well.
of course.
Yeah.
I think a short introduction saying that a good friend of Taslim is sufficient. But okay, Niranjan, Nakul, and Raghav, you can come too. So we represent Malbio and Big Tech Labs, possibly India's biggest and largest molecular diagnostic company. We have an amazing product called TrueLab/TrueNat that is battery operated, can go to any patient care setting and can detect 38 diseases in less than an hour. I represent the strategy team, and along with me, the strategy team has Niranjan Jha, Nakul Pai, and Raghav. Raghav just joined us 2 weeks back, so he's hiding behind. And previously, I was with Bairak. Thank you.
So let's definitely step out for a group photo. And we'll also have a tea break. So let's come back to this auditorium by 10:35. 11:35.
AMR is a silent pandemic, and we have to be very judicious in preserving the current antibiotics what we have. We have some eminent clinicians here who will tell you how desperate the situation is in the clinic. And also in terms of how do we be responsible users of antibiotics in the context of One Health. And the fourth pillar of AMR industry is manufacturing. And we all know antibiotic manufacturers typically are have challenges in terms of controlling the amount of material that goes out in the effluents. So what has happened is of particular interest to this group is the British Standards Institutions is one of the certifying agents identified by AMR to really certify manufacture of antibiotics in terms of how do you put in control measures in terms of knowing how much of effluent goes out, and how do you really tackle AMR discharge or antibiotic discharge coming out of manufacture, which I think is a very important segment in terms of controlling the spread and dissemination of AMR. So how do we operate? We operate, as I told you, we are a facilitator as an organization. We represent across the multiple sectors in the industry. We're very open to collaboration, and we are external facing. We also engage with external stakeholders. This is a very important year for AMR. The UNGA, the United Nations General Assembly in September, AMR is one of the core themes. And AMR Industry Alliance is playing an important role in really bringing in all the stakeholders to make this narrative very strong and really bring some action. And as part of the work streams, so the entire board is divided into different work streams based on the background, and we work on position papers. So what you see here is an axis, as I mentioned earlier, appropriate use, manufacturing, research. Each of the work streams have dedicated resources, time and effort to really come with white paper. So one such white paper which I was involved is a very disturbing report talking about leaving the lab. So what is happening in the AMR field is I work for 2 big pharma companies which shut down, and now I'm glad that I have a job here with Bugworks. So what's happening is a lot of talent, key talent in AMR, which includes microbiologists, which includes clinicians, regulatory people, chemists. They all don't have a job, so they all move out to other areas. So what's going to happen is for us to really fix the AMR issue, we heard about push and pull from Phil in the beginning, clearly showing that the push incentives are working. Multiple players, I'm glad to see PACE as one of the key players coming into enabling the push incentive. The big challenge for innovators like us is the pull incentive, right? Even if we succeed in taking an antibiotic to the market, we know that we will not make any money, and it's very difficult for us to survive. That's been the example. So what is very important is this is a disturbing trend that we are losing a lot of key talent out of AMR field. Even if money was pumped in now, it's going to be hard to retain this talent or to bring back a lot of people. So similarly, we have position papers on enabling access, position paper on guidance around manufacturing standards. So that's in a nutshell. So I'll be happy here to answer any questions about AMR Industry Alliance. And every 2 years there's an annual report that comes out, and I encourage all of you to look through the website. A lot of information on what the industry is doing as a responsible body in terms of tackling AMR. Thank you so much.
Thanks a lot. Good morning, ladies and gentlemen. I'm sure we've had a wonderful 2 hours this morning. I represent FICCI, Federation of the Indian Chambers of Commerce and Industry, and I take this opportunity to thank our host, CCAMP, and the incoming delegation, Innovate UK. Well, I've just opened up the FICCI website just to give you another perspective, which is not on STEM, which is not on biotech, which is more generic. FICCI is one of India's oldest chambers, and it liaises with the government and the industry. We are based out of Delhi, and we have offices in all the states. Our main aim is to basically liaise and connect between the industry and the government, and within the industry. So I urge you all to look at, go to our website, go look at sectors. We work across 80 verticals, across the economy. And for every sector, we have committees and task forces trying to help the industry out. I request all of you to urge and, take a simple membership for FICCI, especially the startups. It's very, very helpful, and it's, I shouldn't be saying this, very, very cheap for you guys to take up a subscription and a membership in FICCI. It helps you connect across the ecosystem in a much more structured and better way. It's not that you don't know to connect, but we try to facilitate things a little better across government and with your industry peers, with incoming delegations, and of course outgoing delegations. And we are here to help you folks. That's all I want to say. So you have all these tabs about FICCI, what's the knowledge hub, a lot of knowledge papers there, the sectors that we work on, the services that we offer, the international connects in our offices across the world, the state offices, how we play out in the media and what are the events that are there. We have our annual calendar there, and of course the last piece is the careers that we have to that are there to offer. So please go have a look at this website, and in case you need any help, please feel free to contact us, reach out to us. We'll be more than happy to help. Thank you very much, and have a wonderful day at CCAM today. Thank you, Dr.
Thank you. We'll move on to the next session, which is a panel discussion. Let's begin a panel discussion. I invite Dr. Taslim Arif Sayed, the CEO Director of CCAM, Dr. Abdul Ghafoor, Managing Partner, Quorum Veda, Dr. Manish Paul, CEO of Microbiome, and Dr. Phil Packer on the dais, please. So I will introduce the panelists. I will start from Dr. Abdul Ghafoor. He's a senior consultant and adjunct professor in infectious diseases at the Apollo Hospitals, Chennai. He is the primary author and coordinator of the Chennai Declaration, a globally renowned document and initiative by medical societies in India to tackle the challenge of antimicrobial resistance from an Indian perspective. He is the managing trustee of AMR Declaration Trust, a public charitable trust founded on the principles of the Chennai Declaration. Apart from that, he has also served as a technical advisory committee on the National Antibiotic Policy. And as I mentioned, he's a managing partner and lead strategist at Quorum Veda Consulting Services. The aim of this particular venture is for healthcare clinicians to come to this side, as he mentioned, that is the startup innovation side. So he will talk about it slightly later. Having said this, I welcome Dr. Ghafoor to Bangalore and to CCAM. We are keen to hear your thoughts. Next, Dr. Taslim Arif Sayed. ठीक है, fine. Phil, welcome back. Then we have Dr. Manish Paul. He is the co-inventor and program director of Enmetazobactam, the first anti-infective NCE to have marketing approval from global regulatory agencies. He's a clinical microbiologist by training and a member of the Strategic Advisory Committee, member of PACE of UKRI. Welcome, Dr. Paul. Yeah. So I will ask for all the panelists to have an opening remark. Then I have some questions, and then we can have a few questions from the audience. Yes, so let's begin. Dr. Ghafoor.
Good morning. I'm a clinician, full-time clinician. I work in a corporate hospital. I'm an infectious disease consultant, and my area of interest is treating infections in cancer patients. And we are dependent on innovations. We need antibiotics, diagnostics, vaccines, molecules, everything. So we are dependent on innovators, but we don't talk to innovators. We don't talk to innovators. A couple of years ago, a founder of a startup wanted a half-an-hour appointment with me, and she has been contacting my secretary for a long time. My secretary won't give a half-an-hour appointment because she wanted to discuss project at an early stage. Finally, she took an appointment. As a patient, I opened the file. What's wrong with you? Oh, I'm so-and-so. I don't have any problem because your secretary is not given an appointment. And that will happen majority of senior clinicians. Recently, Gitanjali Adio, I told you she contacted 100 diabetologists regarding her early stage product for diabetic foot infection, and 3 answered. And that 3 is a big hit from a clinician's point of view. We are busy treating patients. I start my work at 7:30 in the morning. Until 6 o'clock, I treat patients. Then I go home, do reading, writing, my policy work, including sending emails to the health ministry, everything else. And that's the daily routine of most of the senior clinicians in most specialties. We don't have time for additional problems, and startups, in our perspective, they come with us with problems. Yes, solutions later, but currently they are problems. That should change for the benefit of both parties, for the sake of the startups, because they have done mistakes in the beginning. If you collaborate, we are the end users of your technology. And if we are there with you in the beginning, you can do a lot of good things the better and a faster way. From our side, we understand the pain of the patients. We don't understand the pain of the startups. I understood that only recently because as a part of a jury member of the Longitude Prize. That's what changed my perspective. Because that brings us positivity and make us understand the pain of the startups. And not just me, I understood that recently. But we need the medical community to understand the pain of the startups and collaborate. Every doctor should be collaborator with a startup in the medtech. And that will help both parties, the startups and the medical community. And that's the change we want to create with the medical community in India and everywhere. Situation is same everywhere. That's why recently I founded a consulting firm called Quorum Veda. My colleagues, Gafur, are you changing clinical practice? Are you going to start any business? No. I'm still a full-time clinical practitioner. I will remain a clinical practitioner, but I want to spend a part of my time, a part of my frontal lobe and time for the startups. And I want all of my clinical colleagues to do the same. Thank you.
Thank you. I think I spoke in the morning, but just to set the context again, idea was to build this panel largely to have different perspectives, and you heard, Gafur's perspective, very important in terms of engaging because they need solutions in human health from prevention to diagnostics to therapeutics, management, and so on. And I think engagement of that is very, who can make a better case than him? And he has made a strong case, and coming from him, I hope that we can build on that in the panel. So I'm not going to extend on that, but fantastic. And then we have Manish, who, on the panel, who is, who has now molecules in the market, which have, he has contributed and led the efforts of building new antibiotics, which have come to market. So we will have that perspective as well. So fantastic to have you as well. Thank you. Phil.
I'm not going to say much more either, and I think the point you've made is extremely good, and with PACE we're trying to address that. And I think in the UK there are some now, I call them platforms, have been set up, and one of these was used as part of the Longitude Prize analysis. And talking to the lead of that program, so some of the work that she does actually is really early. She'll look at a diagnostic, just to see, in theory, is this going to work? Because as an innovator, you might not know exactly what the clinician wants or the people who are going to do the work for the clinician. And so I would encourage you, if you can, I know it's difficult, but to try and find out exactly how your product is likely to fit into where it's going. Because I think the word that she uses, oh yeah, there was a pipetting product, there was a pipetting stage. She said, that causes instantly a problem. In the so you've got to think about these things. So I really support what you're saying. I'm going to pass over to Manish.
Thanks, Phil, and thanks, Taslim. Well, my perspective, having been through the journey from ideation till the market with one molecule, it was a very short journey of about 18 years. Right? So that means I'm a good husband with a lot of patience also, probably. You got to have a lot of patience if you have to journey with a molecule. But how do you maintain a patent life? When your ideation begins for any kind of a molecule, be it an invention of a molecule or a diagnostic, I would suggest we should look at from the end. Dr. Gafur mentioned the beginning as well. So beginning and the end both have to be taken into perspective, because once you have now we are into manufacturing, and the challenges of manufacturing are also quite humongous. And manufacturing, the waste management, the wastewater management, the regulations are very strict, and AMRIA is quite strong on that. And of course, this molecule I invented was at Orchid Pharma, and I'm still with the company as an advisor to drive it to the clinics and to the market. So there, Orchid Pharma, we thought of PNEC values much ahead of time. Even AMR started implementing it, which means not only looking from the beginning, but also the product side, that entire envisioning. That's what a founder has to do is, of course, I get a brilliant idea. Should I directly jump into finding a solution, or I think through the processes to see that whether I can monetize it at the end of the cycle? Otherwise, our ideas will come to a stage and hit so many roadblocks, and the investors would look at it and say, okay, I see so many problems ahead of it, so I may not want to invest. But your idea and your time has been also lost quite a bit in that process. So thinking through this from beginning till the end, but not to get discouraged. You have to just make note of these challenges and start working in parallelly to see that you address these things as you move along the journey of this, any invention for that matter.
Thank you everyone for the opening remarks. I have a few questions. I will ask them, but please, I also encourage the audience to ask any questions they have. I hope you got some of your answers. If not, please feel free to use this particular segment to ask questions. So we'll ask a question to Dr. Ghafoor. I wanted to ask you the importance of policy, especially in public health and, of course, AMR. I mean, public health in general and AMR in particular, since you have been instrumental in drafting a policy document from a clinician's perspective. Could you share some insights about that?
Policies are very important. If you want to make any change, we need to have a policy change first. And to make that policy change, we need to raise the momentum of all the stakeholders. But making policy change is just a start. Yes, it's a very difficult start. It's just like climbing Everest. But that's not it. That's only a beginning. You need to get that policy implemented. Yes, Chennai Declaration and other initiative created a lot of momentum to implement a national antibiotic policy. But then implementation is still at early stage. The problem is India is such a large country. And we have got 1 million doctors, 100,000 hospitals, so many states. It's very complex. That implementation is very difficult. And that we need to understand when we make a policy. It should be very realistic. And also you should realize that in a country like India, you should have the perseverance to make the policies implemented. But then we realize so many policy changes we made in Delhi with a good intention haven't reached to the ground. But that's the reason that it may not be implementable on the ground. People like me, clinicians like me, took several years to understand why that did not happen. But economists, when Lord Jim O'Neill wrote the report a few years ago, the AMR report, he made a very clear statement. You can't implement a change, make a change, unless you give an economic alternative to the problem. Economists knew that well before. We understood that after years and years of going through the troubles of implementing policy changes. You innovators make that change. Because if I want to stop over-the-counter sale of antibiotic, the pharmacist is losing income. So what we do? We bring a rapid diagnostic on the counter. Let the pharmacist make an income through that test. And so that he is not dependent on giving that antibiotic out for no reason. If you want to make that change, otherwise we will not be able to implement over-the-counter sale antibiotic route throughout the country. That's a reality. Give models, and innovators are very important in creating that model and making that model succeed.
Dr. Taslim, I would like to ask you, how can ecosystem enablers across different geographies work together for problems like AMR?
It looks like that I have set that question in. But I think I think brought in, I think ecosystem enablers are also driven by a cause, right? I think if there is a cause that is driving you as an organization, I think you find ways to address the issues that is around it. And the issues like global health are something that can be right on top of the things where we do know that the projected deaths by 2050 is around 10 million. As I mentioned, it's an understatement, underestimation as well. Right now it is around 5 million, which I believe is also an underestimation per se. We are losing neonatal lives because of neonatal sepsis, which is one of the highest contribution possibly from India. Again, an underestimation. It definitely drives you, it definitely drives you that one could do something to actually address it and bring the number down even by 0.1%. And that's a huge contribution one could do it in life if you actually can, be a causal factor for that. And an ecosystem enabler has a fantastic opportunity because they can actually do it through a larger engagements, right? Which can do it at a larger space rather than your chances improve as an ecosystem enabler rather than an individual specific effort, which is also as important. But somehow ecosystem enablers are in the fantastic position to have multiple shots at it and trying multiple shots, enabling multiple shots. And then exactly there you need to grow beyond your own field and say how I can connect globally and identify people, organizations with the same cause, same drive, and see together how we can do it. And today's meeting is an example towards that, where we are actually having people who are driven to address the global issue of AMR. And our multiple partnerships that you saw on the slide of Phil and something that I mentioned as well is actually an example that there are organizations at the global stage all have realized that AMR needs to be tackled together. And the ecosystem enablers like Carbex, like GARDP, AMR Action Fund, Innovate UK, and many others got to come together. And I think it is definitely a cause that is driving all of us. And I'm very delighted that it's happening without really trying to keep the territories, and protect the territories. So it's a great opportunity to do that. And I think the more we actually look at the cause rather than the means to get there, I think it will actually take us there. So it's a great opportunity for ecosystem enablers to come together with global experts, global leaders, global players to actually go there. And I think that's what is driving us. Thank you.
Phil, I wanted to know a bit more about what's in the UK's National Action Plan. What are the focus areas, and what's the sort of policy about having solutions from different geographies solving UK's problem?
So yeah, I think I sort of put some slides up earlier about that, and I think the action plan. I mean, it's got the areas you would think that need to be covered, and I think the important thing about the action plan this time is I think it has got more of a One Health approach, which I think is really important. I think so. There, I mean, we managed to get PACE recognised in the action plan. I did a lot of talking to people to get that in, because I think it's important to see we're actually doing something. I think one of the things I felt in the past, it was just we should do this, we should do that, and there's nothing actually what is actually happening. And I think the new action plan has got things that we're actually doing now, and I think that is important. Within my area, antimicrobials is one of the big pushes, and diagnostics is very important. And I think diagnostics has been a second cousin, not the most important thing in relation to antimicrobials, but I think it's equally important, and we need to continue pushing that area. Otherwise, I think it is quite a good overall thing of what we need to do. Underneath it now, we need to actually get it delivered, and there will be groups under that to try and make it work. And we'll see how we get on with that. But I think there is more of a joined up approach now in that plan than there was before. Was there anything else I missed on that?
Second part of the question was, what's the policy about having solutions from across the border?
Oh, yeah. Well, I think that it's recognised that there is definitely comments in there about global competition. I think global collaboration, and it's really recognised that must happen. You can't do this on your own. It's a global problem. And as we've discussed, people have discussed here already, the solution in one place is not exactly the same solution that you need in another, but you can work together to try and help get those right solutions in place. Within Innovate UK, I mean, as an organisation, we are based really to support UK, but we are recognising in our strategies now the need for global work, and we've done a lot of global AMR stuff, and so it is recognised, and we will continue to do more global stuff to get these things done. Actually, I'm going to say something. So we recognise globally. We've had you on the Longitude Prize, and we've managed to get you to come onto the PACE advisory board. So I think we recognise that it is a global issue, and therefore we're bringing in international people to help us. Sorry, I should have said that.
Sure.
Dr. Paul, so you've entered you've progressed to the stage where you're manufacturing your molecule, and now this leads to the problem of environmental MR. And so solving one problem of developing a new therapeutic agent and then now scaling it up leads to API generation, and if it's not taken care of, it might lead to furtherment of the MR problem. And you have taken positive steps in that direction. I would like to hear about your latest initiatives in that field.
All right. So wastewater management is a very huge challenge. That's what he's alluding to, essentially. AMR, we have seen from One Health perspective, environment and animal health and human health. We always, human beings, we consider ourselves as the superior beings in the whole evolutionary process. Probably we invented the first time farming, and we took over the food security. But in the process, what we have forgotten is the environmental impact of whatever actions we take. In wastewater especially, the technologies which were developed initially were not meant for detection of AMR genes or antibiotic resistant bacteria in the wastewater, because bacteria themselves were employed as free labor force to treat the water, right? They were the ones who were converting the larger molecules and sediments into non-toxic material. But now we want something which doesn't kill the bacteria. But when the industrial effluent, what we generate, is triggering by adding pressure on the bacteria. Microbes, as all of us who are in the space of AMR know that we are, in our wisdom, negligible in compared to the microbial collective wisdom. Microbes are super smart compared to all of us, collectively, all human race put together. They can predict things more than AI, probably, and tell what exactly man is planning to do. So that's the way I put it, in a very fictitious manner. But the point is, that's a reality. Every time, even when penicillin was launched, before it was launched, we had resistance already detected. That means microbes know every molecule we can come about with. They understand it much better in their collective wisdom. So wastewater, what it does is, when we add reagents to clean the water, they create pressure. Now the molecular biologists understand here that the genetic material doesn't get destroyed until maybe 120, 140 degrees centigrade, right? But in the wastewater treatment, I don't think we go to that temperature. So when the bacteria dies and it releases its genetic material in the wastewater, and that is where the knowledge party happens. Microbes of various species come together and they celebrate sharing genetic information, and MDR strain starts evolving, because not all countries look at zero discharge policies. And some of the countries, I'm proud to say that, including Orchid Pharma, practices zero discharge, and where we are looking at only the release of the antimicrobial substance less than what is supposed to be triggering any of these responses. But what about the genetic materials? I think there is a huge space for innovators to look at how can we mitigate that spread from the environment. There is not many companies, and that's a big area people who would like to explore should look at it. How can I destroy those genetic material before it gets released into the environment? Because from the environment it goes to the lakes. When it says the discharge water goes to the lakes, animals come and feed, and plants are grown. So we consume the plants. So indirectly we are taking it back into the systems. That means we are complicating the problem of effluents in our whole life. So I would encourage everyone here who want to think a little differently, not only look at animals and human health, look at what can be done to support the effluent treatment system. Because systems are changing. I think in 1972 was the last system which was, and Second Amendment came in the UK, where they brought in the secondary treatment process. I think now we need a tertiary treatment process of eradicating the genetic material, which is the core of all the knowledge of microbes have gathered and are storing in that. So I'm glad to say that Orchid is doing its best to say that we have zero discharge, and AMRI has recognized that, and BSI has is now certifying it to be zero discharge company. So I'm proud of that part, of course.
Orchid is a big company. You can afford zero discharge. There are 25,000, in my calculation, 25,000 pharma manufacturers in India, actually much more. As per the government, is around 11,000. You know how many of them are GMP compliant? 1,350. That's all. What about the rest? But we need those companies. They produce low-cost antibiotics and other drugs. But again, many of them, they don't follow effluent norms properly. But we can't just shut them down. That's why we are not very keen in implementing the strict regulation. But we all know the problem. So what is the solution? The solution, again, innovation and startup. You know, apart from the pharma, the company effluent, you know, out of all the antibiotics distributed, 5% of the antibiotics are going to the landfill. You know how that's happening? The pharmacies, if unsold antibiotics should be taken back by the distributor. It's not always happening. 5% of the antibiotics manufactured is going to the landfill because that's thrown away by the pharmacies. And that is significantly contributing to the antimicrobial resistance crisis. What's the solution? Because these pharmacists don't have a mechanism that can be sent to the processing factory. There's no mechanism. So recently, one founder of a startup approached me, Dr. Ghafoor, I know why you are not talking much about the pharma effluent because you know you don't want to shut them down, but I got a solution. We got a technology, plasma pyrolysis, developed by a government agency, and recently this individual approached them, give us the technology, I will have a startup, I will collect this leftover from the pharmacy, I will process it. It's a very difficult business proposition. He will not get any investors in the early stage. I'm sure about that. But this is what we want all the agencies to support. We want such startups to come forward, take the very difficult business decisions, get support of the government agencies, other governmental agencies, provide all the support. If one such startup in all Indian states, we can solve this problem. Similarly, if there are startups for your field, pharma, direct effluent, that's a solution. If that happens, we will be very open about tackling this challenge. If that doesn't happen, we can't encourage the discussion because we need these small pharma companies. At the same time, we are also aware about the Indian pharma's reputation. 60% of our pharma, they are exported, where the image of the Indian pharmaceutical industry is very important. At the same time, we need low-cost drugs. But now we need a balance through the startups, and they will take care of the problem.
Thank you. Thank you very much. I open this session to the audience. Yes, please. Last row.
Dr. Ghafoor, I feel your pain. As an orthopedic surgeon, I had to give up my practice to focus on innovation. And I used to deal with intractable bone and joint infections. Back in the days, when all we had was lavage and plaster of Paris beads impregnated with gentamicin, leave it there and hope and pray to God. So in this gathering alone, I know that there are other couple of doctors. There's Dr. Mahua from Haystack Analytics, Dr. Schuler from Rapid Bio. So we are making, I think, some progress in bringing them together. And also, I hope you feel my pain. I've been trying to get in touch with you so that Andrew Shaw and I can discuss our Atomark or point of care diagnostic device with you. So hope we meet today. Thank you.
Thank you. Could I ask about global regulation? Because we all understand the need to meet the regulatory requirements for safety purposes. But is there a way that we could actually have regulations that are brought together to really escalate the implementation of, say, diagnostics, where you're not involving patients directly, but you're actually doing it away from the patient, so patient risk is minimized?
Okay, so one of the things is if you look at the lower and middle income countries, that is where the major challenge comes. One of the things what I see, which even Taslim was mentioning, the rates, whatever published data comes, is my personal opinion. I really do not believe that data is a true representative of any country's real data in the LMICs, where we do not have proper diagnostics, starting from sample collection. If the wrong sample is collected, if the sample is not collected appropriately for a microbiological purpose, you are isolating a commensal and looking at very different data. So now the governments are waking up. And I'm really proud that Indian government has now participating in this NAP, and we are coming, and the state government is participating. Few of the states around Karnataka have already taken it up. Now, when the government comes into play, I think that is when that change can come in what you're asking. This implementation has to happen from the top down at a policy level. It's not only policy, but the implementation of the policies. Policies, writing and putting it on a deck here, that doesn't have any purpose. Engaging the stakeholders. Like Dr. Ghafoor mentioned, having a diagnostic test at the counter of a pharmacy, and I like that idea because I think that I never thought of. Most of the pharmacists are blamed that they are giving the medications. In India, it is very popular. Over the counter, you can just get, you name it, you amoxiclav, you want levofloxacin, you just get it right there, just like Poppins. That is because the patients go on demand. The clinician's fee may be larger, or the disproportionate ratio between the clinician and the patient. Nobody has the time to wait there on a line. The pharmacist knows the pharmacokinetics partially. He's okay, this works for this, he administers. Now to beat that diagnostic on the point of care at the pharmacy is very important. Now these kind of decisions, if the governments take up and start implementing and encouraging and have some special funding to encourage that practice, I think a major amount of burden of human discharge or human contribution towards AMR will come into control. That's what I think so.
So in the therapeutic domain, we face a problem when we write what is the business size, market size for a novel therapeutic against water. So I hear with interest Phil mentioned about the Netflix model and being adopted by some other European countries. Can you tell a little more about that, please?
So the Netflix model is it went through and it's done its pilot. So essentially, NICE have been running that for the UK, and they value a product at phase 3 or license, and then they basically pay the company so much money as if they're going to sell it would cost sell that product in the future, because the problem is, if you've got a new antibiotic or antimicrobial, it's likely not to be used because because you only want to use new ones in the last resort, because you don't want to get resistance. So that is what they're doing. And in the UK, they are now going to extend that and bring in other projects. But we've recognised that solution is not going to work unless other countries do something similar. And now there are countries talking about this because so the US, the Pasteur Act would help, but that keeps getting stalled politically. I know Sweden are talking about things there. So there are. We know that other countries are trying to do this. We will then be able to have the ability to have enough products on the shelf and paid for, and therefore that will allow investors, because that's what we need when we get to phase 2 and 3, to realise that there is a market, even if the market is that it won't be used, and therefore you get the investment. So it's really important, and it is something that has got to be really pushed. I think Dame Sally will be doing that again at meeting in the autumn, because if we don't, it's no good just a couple of people doing it, it won't work. So is that answering your question? It's got to do, and therefore we need to now start getting the push incentives, because they will take a while to get through. If we don't start, if we don't start those until we got all the pull incentives in place, we'll have a big gap. So we hope that we can get those pull incentives ready, so when these new push things come through, that we meet, he says.
Hi, this is to Phil. You mentioned that antimicrobials are the larger story. The smaller cousin could be diagnostics. I somewhere feel that the veterinary use of antibiotics is probably orphaned. Just to give a context, we work in aquaculture. So if you look at a simple one pond of an aquaculture pond, you probably have anywhere between 5 to 10 million liters of water, and then somebody's dumping in 10 tons of antibiotics. So 40% of ponds in India have Staph aureus MDR strains. As a regulator and policymaker, what are your thoughts on
that? Is an issue, and I think one of the things that the UK again is now pushing on is vaccines. I know vaccines is not always easy, but that could be a starting solution. Sorry,
vaccines are impossible in aquaculture.
Well, there are some people trying, but I understand that. So there is an issue there. Yeah.
And going back to the economic model, it's good for us to sit in a boardroom and say don't use antibiotics, but the farmer livelihood is almost gone if they don't use antibiotics. So it's kind of a catch.
And I think there is something. One of the we came out on an exploratory mission before we came here, and we had a couple of vets on there, and the antimicrobial free is not the answer, because you do still need antimicrobials to look after animals if they're ill or whatever. It's just used for the wrong thing. So we need to make sure we use them properly. Yeah, the yakka one is a good point actually, and something I hadn't really thought about probably. Anybody else want to come back?
Just to, I think, come back. I think this is a classic example where alternative agents which can take care of infection in aquaculture, right, possibly will be the economics driving force rather than sectoral or policy level driving force, where you possibly will be able to provide a solution to shrimp exporters, that we will give you a solution, and through this solution you will not be able to be banned because of antibiotic stresses, and because you will not be banned, your bottom line will improve. And that's a simple, economic way of going, rather than going the larger issue of AMR, because that's what a businessman and a customer would understand. But of course, it's definitely a good way to let the funders know, ecosystem also know that these are important things, so that we can support you back, because sometimes it gets the scale of usage in other systems actually gets ignored, but this is significantly high and remains long because of the food chain that actually it follows eventually. So it works both ways. Yeah, thanks.
So for my ignorance, in the UK we don't have such a big aqua farming industry as in other areas of the world. So that's probably we've not thought about it enough, or I haven't.
We are very well aware of the veterinary and aquaculture, agricultural antibiotic usage. Now, colistin is the most powerful antibiotic in the human world, and that's again the most popular antibiotic in the veterinary world. We got it banned in 2019, and that needed a lot of effort, policy pushing, political pushing. We could get it banned because of one reason, because of 95% of the veterinary colistin used is imported from China. And we could use that particular part to get it banned. That's how it worked. But we are not able to replicate that particular process to other antibiotics. So banning it is, you can make a policy, but I can promise you it will not be implemented. In the human world, we could not implement over-the-counter rule sale. So forget about the animal world. The only solution is economic alternative. Who will oppose from the colistin ban? It's my own personal experience. The opposition was not from farmers, not from the policymakers, from the distributors. And it's a powerful business. It's a powerful business. You can't oppose them. So what you do, you need to give them an alternative financial model. Bacteriophages, vaccines, nutraceutical, you name anything. If you have an alternative and give that income loss, if you can compensate with an alternative business, you can get the antibiotics banned. If you don't do it, that ban will not be implemented.
Yeah,
When you say no vaccines, of course there are no vaccines for aqua, but definitely Look at the Ganges, our river Ganga. It's mainly because of the phages, right, which are controlling. So we need to figure out those ways of, alternative ways of dealing with AMR in pond system, especially bacteriophages. We have Gangajan, there he is, see. So he would probably give some ideas there as well.
Yeah, to add to the point, we at Aristogene, we work on bacteriophages. And we know that AMR, one of the reasons for AMR is misuse and abuse of antibiotics in poultry and aquaculture. And shrimp cannot be vaccinated because they have a poorly developed immune system. So last 8 years, we have been developing bacteriophages for poultry and aquaculture. And we are proud to say that more than 1,000 farmers are benefited by the use of bacteriophages in aquaculture, because we have export rejection because of antibiotic residues in aquaculture, and 90%, 40,000 crores worth of product is exported in aquaculture. So antibiotic use is reduced and farmers are aware. And we are very proud to say that a farmer in a remote village in Andhra knows about bacteriophages and they use. So this is what we want to add.
We came late, we couldn't introduce ourselves.
Thank you.
What's the company name? Aristogene Biosciences.
A very insightful panel discussion, I must say. I have two questions. One is to Dr. Ghafoor. Sir, you have been closely involved in the antibiotic policy for the nation. There was a concern for me, and I wanted to understand it better. With the dearth of multidisciplinary teams across the healthcare infrastructure in our country and the lack of mycological laboratories across the country, mostly even in the tertiary care centers of tier 2 or tier 3 cities, where do we stand in antifungal stewardship practices? That is a question to you. The question to the panel is, should we and are we, that is the government from across the globe, thinking of global antimicrobial policies because of the globalization and the intense travel that we now see? And that would mean sharing a transparent data sharing in terms of the organism profiles, the genotypes, and how well or how comfortable are governments sharing this across borders? So that is an open question to the team.
The first question, antifungal stewardship. A good percentage of the medical community are still unaware of fungal infections. Antibiotics are so underused by majority and overused by those who know about fungal infections. So when you talk about antibiotic stewardship, you need to take these two particular aspects, contrasting aspects, into consideration. How to get it done? We need to increase awareness of fungal infections among those who don't know, and then rationalize antifungal usage among those who use a lot of antifungals, like myself, who treating cancer infections, where fungal infections are one of the commonest cause of infections, and cancer patients die of fungal infections. But we overuse antifungals. So we need stewardship in that area. Second question, sharing of information. Globally, we should share information. There should be a common platform. But your concern is right. We're not just our country, all countries. When you come to the really about the confidentiality of data, there is hesitancy in data sharing, and that is applicable to all countries, in all fields of medicine, science. But there should be some level of transparent data sharing. Without this data sharing, global policy making cannot happen. And antimicrobial resistance is one area where we all have to work together in a transparent way.
So then do we see the middle fielder as a person who can anonymize data and have help in building up a policy which is more global? Because they would be working closely with a lot of countries.
So in a way, I think human health data sharing, direct data sharing, has been always a sensitive issue, and I don't want to wrap it in any other word. It has been for all countries, right? Because we do not know how those could be used. However, there are several platforms which are now coming together and happening, which including cancer genome platforms, the global other platforms which are coming and building where the data can be accessed across after anonymization. So there are platforms which are being created which are anonymizing data and providing the access. It may not be always the level of accuracy that one needs. The data convergence is not happening at many places as well. Many hospitals have data, but doesn't go beyond hospital, right? It doesn't go beyond hospital itself. So we have a lack of that. I would believe this would be one of the key point, even while we don't want to be global, as even for a national effort to understand where the data is coming from, build a national data platform, and then also have an aspiration of making it globally accessible, because I believe we are not yet cleared the first hurdle of national appropriate data platform actually. So that is something that we should all work towards, talk about and make an effort towards. And I'm sure it is, as in our national action plan, it is also being built through the ministries which is coming out. So that's.
Can be anonymized sharing, so it can help the national policy.
Exactly. So there has to be from the data collection to the data collation, and that is something that step has to happen through the hospital, and that is something we'll have to do, because a lot of diagnostics players here who will be actually having the data, hospital path labs who will have the data, how then after collection that data actually get collated somewhere is a step that possibly needs to be worked on. Thank you.
I have a question for Dr. Gafur. You highlighted about diagnostic test on the pharmacy counters. I'm curious to know what kind of parameters needs to be tested at the pharmacy counter itself.
See, the pharmacist will not be able to spend a lot of time talking to the patient. If somebody is coming with a urinary infection, the patient should be able to give few drops of urine, and the pharmacy counter should be able to add it into a rapid diagnostic test, and that diagnosis test should be accurate and affordable. If these two parameters work out well, the pharmacist will use the test. You can't take detailed history. It should be based on the technology.
All right. Also, you highlighted about the policy making, like diagnostics, including the policy making. Also, it's a level to fill, So all these policy documents highlight supports the diagnostics, maximum tells about the rapid diagnostic, but it is not talking about the futures that diagnostic tests should have, because it is quite clueless what directions should that innovators focus on, like whether like I was talking with the customer, with a definitive diagnostic or a phenotypic or genotypic. So why not policy document highlights this information as well, so it will help us to focus more on it.
I'll take a quick shot. I think in a way that policy may not be able to go and dictate to a physician that what actually he or she has to use. To be honest, it's, as I mentioned, it's the circumstances, it's the criticalness of the result that the physician does need in space, either in OPD, either in inpatient, in ICU, or whichever it is. So whatever is available and they feel that's the right comment, whether it's a genotypic or a phenotypic, they will do that. Right now, I don't think that there is a directive, and I do not individually, I think that there cannot be a space, because physicians have to have flexibility in understanding where it is. I'm sure that there are places where one could actually say that this is the best, but I think flexibility has to be to a treating doctor in terms of what they want to do. I think it will go very far in terms of dictating what they need to have before one does that.
So it boils down to independent clinicians' decisions.
Yeah, and with respect to us, if we don't want to stifle innovation, so if you say you've got to go down that route, you then might end up something that is new, which would help a clinician, just doesn't get funded. And we do get criticised if we do not have when in funding things in general. If you do focus, somebody will say, well, what about this? You haven't thought about that. So, for example, you could say we're not going to do phages in antimicrobials. Well, that could be disastrous in the long term. So you've got to have it open. You've got to have it open.
Yeah, because when we approach clinicians, I'm sharing two kind of technology, genotypic and phenotypic, because we developed both. Mostly they prefer phenotypic test. So still, clinicians' preference is over the phenotypic test. That's why I was wondering why not I highlighted in the policy document itself. It will help us to also convince the investors or somebody.
Yeah, It just won't go. No, I don't think
Policymakers won't be able to support you, but if you believe your technology is better than other technologies, you will be able to convince the clinicians. And we are the end users.
Yeah. In interest of time, how about we continue this over? There are lunch because there are 3 more that popped up. So
You have to have.
maybe we can. Sorry, we will continue it later if you don't mind. Yeah.
I will just add to the global collaboration my thought. I'm a clinician with a background in the clinical development. I've been lucky to be into clinical development 25 years back when my professor was interested in developing new drugs, and then I started in the clinical development. So this is a big challenge, and the ultimate goal for any innovator for global collaboration is global approval. That's what we should target to. And as such, regulators, they appreciate multinational clinical development. There are policies from the guidance documents from US FDA, EMA, about that, and that time of course MHRA was leading EMA when those guidelines came, so UK definitely it would be acceptable, but we need to understand what is the standard of care in different countries. And within India the challenge is that tier 2 and tier 3 cities also will have different standard of care. So that's why in our company we have we are 6 physicians, so physicians who are also board certified in the US, and this is something, the gap that we see between what an innovator is developing and what Dr. Ghafoor was highlighting and what is the clinical practice. That's very, very important to consider right in the beginning, and there should be perspectives brought in, because the medical science is developing so far that being a clinician also every day I'm learning new things about the standard of care within India and outside India. So that is something that needs to be highlighted more, and innovators should get more support in that area.
Thank you for the comments. I conclude this particular panel discussion. Thank you everyone for this wonderful interactive session. So quick series of announcements. Now we'll break for lunch. Please follow me, Ganga and Purnendu that I pointed out later. We will escort you to the neighboring building where we'll have lunch. Then we'll come back here and we'll start the next session. You can leave your bags and belongings here. We'll lock this room so they'll be perfectly safe. Please follow me, Ganga and Purnendu. We'll be outside. We come back. Okay. We'll come back by 2. We'll gather here and settle by 2. Yeah, let me put that. You can start from the ground floor. Yes.
Yeah, I was due to have a meeting start at 1:45 with an external person, so I'm not sure if they're going to be wandering around the building, wondering what's happening.
You can be stage leader if that is fine.
Yeah, no, it wasn't organised by me. It was.
Dr. Kaushik, Dr. Paresh. Yeah. Purnendu or Dr. Paresh. Yeah. So first 3 rows, please follow Ganga.
So basically, this is the CCAM building where we are currently going to see 50 floors. And what we have is a layout which is an open lab where these are incubation spaces where some of the startups who spoke today are housed. And it also houses different facilities, as well as the in-house R&D team, which is the Discovery to Innovation Accelerator, where we work with a lot of very good, phenomenal academic discoveries which are not ready for industrial uptake right now. And we work for the TRL2 to TRL5 there in these labs. So if you have seen this floor area, so a lot of startups, there are no boundary walls which have been created. All the startups are sitting together and they share benches depending on their requirements. If they rent out a bench or an entire aisle. And in this floor we have some of the startups which are working on cell-based therapy. ISTEM is there and Endure is there. So they are mostly using the cell-based therapy. They are doing pioneering work in different sectors. And all the different floors that we will be walking through, we will have different sets of facilities which are CCAM facilities, and we have a lot of startups incubated. So there is no wall which is separated. The major idea is that the ideas should be flowing and there should be a free flow of interactions so that early stage innovations can happen. And a lot of good ideas actually have been discussed here in this open ecosystem over coffee tables where companies from focusing on different areas, they were able to pivot because they were able to interact with the other innovators. So the idea was that we started with 2 floors now because so many people are requiring such shared spaces which not only provide a common space but also provide high-end facilities. When we entered, the first aisle had all the high-end equipment. We had a fax machine, PCR, which the startups may require in the molecular biology space or early stages. And on the other side, we have all the larger equipments, or we have a lot of the bigger liquid handlers where you can do antimicrobial screening. We conducted a project which was around 15,000 microbes which were grown in the machine, so which is so all the liquid handling, the incubation facilities are there. So we were able to conclude the entire 15,000 isolates screening for antimicrobial activity for agricultural applications or any applications within 2 to 3 months time frame, which otherwise would have taken, in the absence of such a facility, 2 to 3 years for us to screen that big number. So slowly we have curated all these facilities which are required by Indian startups, and all of these things are made available to anybody who incubates. Some of them are paid facilities where they can access them based on fee. Others are parts which are coming with the incubation. And we have specialized facilities. Possibly once we go up, we have separate areas for culturing the microbe. We have for P2 facility and BSL facility for culturing viruses as well. When we start walking through up, possibly we'll go to the second floor next, where we have the index program, which is indigenization of diagnostics. Possibly we'll talk about it when we reach there. Yeah.
Balancing that up was just sort of going wrong.
I love so much about weather sector in Bangalore. You can just have a constant outside facility.
Then the quality of those imported kits wasn't great enough, and they were super expensive. In terms of cost, it was 5,000. So at the start of the pandemic, the cost of one RT-PCR test was actually 4,000 to 5,000. So it was not we were not able to reach the masses. So that's when the government of India took a decision that we need to start indigenizing the diagnostics and so then the index program was brought in. It's INDX. It stands for Indigenization of Diagnostics Program, and it's anchored out of CCAM. And so that's when we started building a huge platform where we brought in Indian IVD manufacturers, and we also brought in reagent manufacturers from India. We brought them together so we also identified in the process that there are a lot of supply chain gaps. So we tried to all fit them all in, make them recognize that okay, you have suppliers right over here. Why do you want to go for imported products? So because what was happening is there were some Indian manufacturers of say oligos, the amidites, and they were manufacturing it and selling it to the global companies like Thermo and others. And then those were being brought by the Indian companies, IVD manufacturers, and that was the whole excess money flowing around and all. So that's where we tried to cut corners, and we tried to make them realize that okay, we can build quality products in India itself. And we have all of these companies and research institutes, onboarded with us. We have 250 organizations right now, which include not only the diagnostic kit IVD manufacturers themselves across technologies like CRISPR, we've got NAT manufacturers, NAT-based, which includes RT-PCR, RT-PCR, CRISPR, and LAM. We also have LFA manufacturers. So initially, the program was focusing only on COVID-19 and diagnostics for SARS-CoV-2. We also had through a manufacturing sample collection, vials and tubes, and then RNA extraction. So we were completely focused on solutions for COVID. Then, and through this entire effort of bringing everyone together, we were able to reduce the cost of the IVD itself, the reagents also, master mixes as well. I have a few brochures here that I can actually hand it out to you. So, and then when the pandemic waned, we switched gears, and now we are trying to indigenize IVDs for a range of 10 infectious diseases. So there are 3 primary areas that we are looking at. The first one is undifferentiated febrile diseases, AUFs, which includes 6 diseases, which are chikungunya, malaria, and dengue, leptospirosis, and scrub typhus, and one more. And then we have a respiratory panel, which includes SARS-CoV detection, influenza A and B detection and extinction, and then we have RSV infections. So, and then the third category, which of course is a global priority area, is TB diagnosis. So we are focusing on enhancing Indian development of Indian IVDs in these areas. So, and while we are doing this, we are also making sure that we up the quality of the products. So, what we had done in the first phase of the program was that we had established 8 to 9 centers of excellence across the country, wherein each of those centers of excellence had an expertise in a certain aspect of product development. So we had one at ICER Pune, which was the COE for chemistry. So they had the nucleic acid chemistry expertise, and anyone who was dealing with, say, oligos or amidites, they could send in their products over there, and we could get them quality tested with different physicochemical methods. And then the functional testing was also being done by Index. And all of these projects, we did like 100 plus projects in the first phase of the program. We did it for free. We didn't charge anything. And one of the main bottlenecks that we identified at the start of the program was that people were making diagnostics, but they were not able to get access to clinical samples. So that's where we identified the Next Door Institute in STEM. Professor Colin over there, he developed a biorepository of 7,000 plus SARS-CoV-2 samples, patient samples, which were also sequence verified. So, we knew that, which variant and subvariant we were looking at. So then we did several projects with them, because the problem was that when the manufacturers were trying to go to IT, we kind of facilitated the entire process. Several of the kits that were kind of assessed by us and given a green signal to go ahead actually got the ICMR approvals. So we kind of facilitated the entire process of getting Indian regulatory approvals. So that's what Index does. We are trying to do the same thing for the other delegations. In case anyone's interested,
Also to add, as well as the kit manufacturers who are there part of this consortium, who are available with Index, and they work with them very closely to understand what their pipeline is, and they work with the startups who want to manufacture their things. And they also, because of the COVID times, they have a network of people who can actually help them productize it much faster. The pipeline is very well now reached for the molecular diagnostics for the things that she has mentioned. And now they are also trying to expand it to other, like ELISAs or others in terms of the network. So if some of the UK startups who wants to
Yes. Let's make our way down. I think the next group is already here. Oh, they're here. Yeah, we saw. So I'm going out to the ground floor now. The idea was to have it in India. This came up during COVID. Make in India. Exactly.
Yeah, we have this ecosystem. Yeah, we have this entire ecosystem. We have different organizations. So those those kind of assemblies. No, but it will be good to have you on board because we can then direct it to you, right? We can see how that
is part of the INDEX program. INDEX stands for International Diagnostics, which we were just talking about.
Okay,
so
great.
over to you. Please,
sure, thank you so much. So,
yeah.
hi everyone. My name is Richa and I lead outreach for the INDEX program. INDEX is basically indigenization of diagnostics, and the program was started in 2020 when the pandemic hit us, and there was a realization that the RT-PCR kits were pretty expensive. They were like 5,000 rupees per test, so we were not able to reach the masses and all. And then the government realizes that there was like a 70 to 80% dependence on global market for our IVD kits, and then they were not of great quality. They were taking time to come here. And so then this program was initiated, and it has since then been anchored out of CCAM. And so we built a consortium of indigenous diagnostic kit IVD manufacturers. While we did that, we were also trying to identify the gaps in the supply chain. And then we brought in the reagent manufacturers also, again from India, and we made them kind of recognize that, okay, you can get this raw material from India in a much cheaper price and at a good quality also. So that was, and then we also eventually brought in ancillary product manufacturers, people who are doing, the plasticware, the packaging for the IVDs. And then the last year that we brought into the entire ecosystem was those of service providers. So people had diagnostic kits ready, but they did not have the capacity to scale it up. So we got them connected with OEM manufacturers, who could kind of scale it up for them. And we also did, so they were like smaller startups who had the kit ready, but didn't have the reach to the Indian market. So we got sales and marketing teams onboarded. So that's the way, we try to identify what were the needs and, kept on expanding our network. And right now we are 260 organizations strong, which includes not only the diagnostic kit and these manufacturers, but also from the academia who are building novel technologies. So we've got IITs as a part of us. The products, the raw material that they've been procuring. So then we connected them with the Indian manufacturers of those raw materials so that they can substitute and they can still do their clinical studies and go ahead and with a much cheaper price. So that's how the model worked. And while we were doing this networking thing, we also made sure that people were getting support in development of those products. As in, we set up centers of excellence across the country, which are based out of the top academic labs in India. CCAM, INSTEM, NCBS, ICER, CCMB and all. So in each of these labs, we identified an expert in a certain domain. Like we had at ICER Pune, we have Professor Srivatsan, who has nucleic acid chemistry expertise. So anyone who was coming up with, say, DNTPs, oligos, amidites, and they wanted to get their quality testing done, a comparison with their benchmarking study done with a global benchmark. We were doing it at these centers. We had it for chemistry, we had it for quality, we had it for clinical studies. So we also realized that people had IVDs, but they did not have access to clinical samples, to actual clinical samples. The matrix is different, and they are using something else as a matrix, so it wouldn't really work in the clinic if it goes out. So that's when we established INSTEM as one of our centers of excellence. We had Professor Colin Jamora, who was leading it, and he built a biorepository of 7,000 plus COVID patient samples, which was also sequence verified. And that it's a variant and variant we're looking at. And then, we supported a lot of these tests on nucleic acid extraction kits. We worked on LFAs. We also worked on RT-PCR. And I think we did LAMP as well. So we did around 100 plus projects, and all of these were done for free. So, and once they got people would come to us and they would say, okay, just go ahead and do the clinical for it. But when we realized and went through their data, we realized that no, it needed some analytical assessment done before. So we supported them there. We guided them on how to improve it. It was a very iterative, process. Then we took them into clinical testing. When it did well, they took those reports. So we were not certifying anyone. They took those reports as supporting data when they applied for the Indian regulatory bodies, CDSCO and ICMR. And that helped them get the approvals from there. So ICMR did their own validation, and a lot of them made through. So yeah, that's what we did in COVID during the pandemic. After that, we shifted gears, and initially it was funded only by Rockefeller Foundation, And in the second phase of the program, which was launched last year, we were now funded by Bill Melinda Gates and FIND as well. So, and then the focus changed as the pandemic waned down. The focus changed to the next set of priority diseases. So we identified three disease areas. The first one was AUF, which is acute undifferentiated febrile diseases like chikungunya, dengue, malaria, leptospirosis, scrub typhus, and typhoid. Then we have a second category, which is respiratory panel, which has influenza A, B, and any IBD that can distinguish between them. Then we have COVID-19, of course, and also RSV infections. The third category that we focused on was pulmonary and non-pulmonary TB. So these are the disease areas that we are working on right now. So V-Index itself is not developing a product, but we are facilitating connects so that people. So right now through BMGF, Bill Melinda Gates, we've been able to bring in WHO India, who's guiding the Indian manufacturers to aim for WHO PQ. So we've done one workshop. We're planning another one at the year end. So that's how we are trying to help them up their quality level as well. So people say that okay, if we get the ISOs and all of these, it adds to the cost of the product. But in the end, they have to have a far-sighted feel about it. I mean, if you pay for it now, you'll make sure that your product goes to a bigger market later, right? So that's the kind of sense we are bringing in. We are supporting again through a network of hospitals that we've identified. We are supporting the clinical validation of these kits as well. So that's where we are right now.
And for all the products, services, and even clients, have you built some sort of marketplace to connect people?
Exactly. We did have a digital platform. A really nice one actually. TCS helped us build it pro bono for the first 3 years. And that was one place where people had to come register. And everything was free of cost, nothing was charged for. And then they could network right over there. And those 4 tiers that I told you about, we had subcategories within it. So within, say, diagnostic kits has one category, we had subcategories. LFA manufacturers, sample collection kits, we had RNA extraction kits, everything was segregated. People who had products for each of these categories could come and register over there. And they could find each other.
I hear a lot of past tense. Is it gone?
Yes, unfortunately, yes.
Is it going to come back?
Is the server down?
We are trying to. So the charges were pretty high now that the pandemic is over. So we are trying to figure out how to bring it back up with a different vendor. So
after TCS,
exactly.
it's not a not-profit.
Because they did it pro bono completely for the first 3 years, and it was fantastic.
The maintenance charges.
Exactly, the licensing of the platform itself was a lot. So they did it on CSR basis, and it was a fantastic platform. We put in a lot of effort on it. But we are sure to bring it up again with a different vendor. And that's where we are. We are 260 organizations trying to constantly interconnect and
So now put a revenue model on it as a sort of slight
That's
thing,
exactly was the plan. That's exactly was the plan. We were doing it wholeheartedly free for everyone.
So how do we connect now that the platform's with them?
So I lead outreach. You can take my email ID, my phone number, and we could stay in touch. And index features on the CCAMP website as well. You'll find all the details there. And
You still have all the databases?
Of the yes,
from
of
the
course.
TCS system?
Yeah, absolutely. We have the backup.
And they'll let you have them, or they'll...
They did. Yes.
Just not use them, but you can
Yes,
have
of course. But we have the back-end data. I have all of it with me. We are just trying to figure out the right vendor to go ahead with so that we can bring it back to life. But it was very, very helpful having that platform.
So with the hospital records have a need.
Okay.
Example, I want to develop for human papillomavirus, which we are doing a lot of research on it.
Okay.
How do you help us?
So if there is a specific need, we could connect you with the companies who have the capability of doing it.
No, we can develop and we can do that.
Okay.
We have samples.
Okay.
You beat any bacteria, virus.
Okay.
We have stocks of thousands. And in COVID, we have almost 1 lakh samples with us. So now what we felt was human papillomavirus. One of the things that we wanted to do as a screening method.
Okay.
So where the screening was not done here in India.
Okay.
So we have found in one district 10% was the positive rate.
Oh.
High risk, not low risk, high risk.
Oh,
so now there's a need for us to develop low cost kit so that we could screen a lot of people
Yeah.
So maybe I'll connect with you and see how we can work.
Absolutely. So you want someone to develop the kit for you and
Yes,
do
it
the
would be
analytical?
good, yes.
Yeah,
Validation we can do
definitely.
because we've developed the kit actually.
Got it, got it.
So
We
clinical
have ample
samples and
number
all
of
that.
manufacturers who
Great.
could support you there.
Great. So we can do that. Yeah, yes, we can do. See, already there are kits that are available, but they're very costly.
Okay.
We use the kits to manufacture in Germany.
Okay.
And in US.
Then they will not
Yeah,
be
so
available to the market.
yeah, somebody in the village they can't afford. That's
Absolutely.
daily wages for them to.
Absolutely, absolutely. So, if you want, I do not have a card though, but if you can give me your card,
I will
great.
share details to the entire delegation.
I'll contact you.
Sure.
We are very much in need of.
Absolutely. Because if we find out such gaps, see, so Index has its own priority disease areas. We couldn't support you. If we are not able to support you there, like HPV is not one of the priority diseases. We could connect you with the manufacturer who could support you there.
In India, the cervical cancer number 3. So we can avoid by just screening, following up in 1 year.
Right.
So,
Right.
Yes. We do kids, yeah.
If somebody had questions about the pricing of our different services, we can take that conversation slightly separately. So let's move on to the networking session of the day. So we have slightly changed things from original thought. What we are doing is each UK startup has a designated space in terms of tables that you saw all over. So basically ground floor and second floor, there are dedicated spaces. Each UK startup with a particular name, particular number will be sitting there in that particular area throughout the networking session, while everybody who wants to meet the UK startups can go to that particular position. We all know we have this reference sheet. We have posted it outside. Please, so we will guide you to the appropriate space. Yeah. Yeah. So yeah, again, I've made the list alphabetically. So the first 7 people, please follow Ganga. These are Automarker, Barefoot, Secal, Sitecom, Airbajan, Folium Science, and Lightox.
Please follow me.
Yeah. You will that I'm announcing: Microbira, Phytoceutical, Presumption Health, Ramenomix, Rapid X Bio, the UK one, Atabrix, and Whitech. Just give 2 minutes for these guys to settle in their spaces, and then we can start meeting them. So it's essentially the ground floor and second floor. So 2 floors where these companies are evenly divided. We have no official hard stop as such. We can go on till 6, so please don't restrict yourself thinking 4:30 is a hard stop. I hope it's okay with you. The campus is accessible till 6. Yeah. So yeah. Let me just
Yeah, hi. My name is Vasan Sambandamurthy. I work for Bugworks, a 10-year-old company incubated in CCamp. We work on two priority areas which shape humanity. One is antimicrobial resistance, other one is oncology. In the AMR space, we are developing a broad spectrum novel antibiotic belonging to the novel bacterial topoisomerase class that's currently undergoing phase 1 studies. This is truly a broad spectrum antibiotic in the last 6 decades. What is interesting for us being in CGAMP is the infrastructure, the networking, and access to resources is fantastic here. And especially in the UK angle, we do have investors from UK. Lord Jim O'Neill, who authored the seminal report, is one of our investors in Bugworks. Plus, Bugworks, two of the co-founders from Bugworks are ex-AstraZeneca, a UK-based company. I am also an ex-AstraZeneca employee. So we do have a lot of connects with former colleagues from AstraZeneca who are based out of UK, and we do have academic collaborations. So, in a nutshell, Bugworks is extremely delighted and thrilled to have a strong collaborative network with multiple academic groups and investors across UK. Thank you.
Taking forward the conversation of collaborating between of the collaboration between UK and Karnataka in the light of the recent visit of the state's delegation to UK, where significant conversations have happened not just with Innovate UK but several other stakeholders in the country. We've had a lot of interest from both ends to take forward this conversation on a bigger platform. In that context, I think with Karnataka and Bangalore being the startup hub for India, with a significant number of startups and a lot of innovation activity happening out of Bangalore, we would be happy to work with global entities such as Innovate UK to take forward these partnerships, because we understand that there's significant interest from both parties, with a lot of startups from UK looking to expand into Indian markets and a lot of startups from India looking to expand into global and European markets through UK. So we would be happy to take forward this conversation, especially on the biotech and AMR front, since we realize that AMR is a global problem which needs a global solution, and for that we need global partnerships. And we would be happy to work with like-minded stakeholders in order to solve a problem which is not going to be an easy one to solve, to be quite honest. So we look forward to this collaboration. Thank you.
Hi, good morning. I'm Dr. Zille Anam. I'm a Senior Program Manager at UK Research and Innovation at the British High Commission in India. We're very excited to be a part of GBIP, to bring a business delegation focusing on antimicrobial resistance to CCamp today. And we're hoping that we're able to build a lot of business-to-business collaborations, networking opportunities for us as countries, as UK and India, to come together and solve the challenge of antimicrobial resistance. It's been wonderful to be interacting with the Karnataka government, with the businesses housed at CCamp, with the management and administration at CCamp, and we hope to be able to bring these discussions forward and collaborate for the human good. Thank you.
Sound check. Okay, I've been asked to explain why you should come on a GBIP. My name's Scott Perkins. I'm from Vitec Microgenics, and I'm here in CCamp in the lovely city of Bangalore. We came here with a few objectives. One of them was to learn about the market and to understand the Indian market for our products. Innovate UK obviously have got way more connections than we have, and can facilitate introductions to this wonderful campus and some wonderful people. I'm surrounded by lots of innovators here having meetings. So the level of market access you can get, the level of introductions you can get is really amazing. The other thing actually in GBIPs, which I think is not known enough, is how much you get from learning from the other innovators from Innovate UK. You basically get to spend a week or maybe even more with some really incredible other CEOs from other startups in the UK based in your field, based in your area of study and commercialisation. For both these reasons, GBIPs are fantastic ways to take your business to the next level. Thank you. Good luck.
खाली से
Yeah, it's been amazing participating in the GBIP and coming here all the way from Cambridge. We've got to meet companies that have really opened up our mind. Just the last conversation we had was with a company that has grown from one founder to 10 people in less than £100,000 and got clinical validation and bootstrapped. It just tells you what is possible just out of the spirit of innovation, and how dynamic this system is. And we are learning a lot from the system because we've been able to talk to a hospital chain with maybe 20 multi-speciality hospitals that wants to test out our system. We're It's been immensely helpful. I'm Nipun Sani. I'm the founder of RapidX Bio.
Yep, I'm Shula Zhu. I'm the co-founder and CTO of RapidX Bio. I think this experience, the companies here have been absolutely phenomenal. Like, there's a lot the UK cohort has to learn from this trip.
Yeah.
Totally agree.
And we're immensely grateful to UKRI for this opportunity and Innovate UK and the delivery partner Birmingham Chamber, I think. They have been absolutely amazing on this journey for AMR, and I think India is the place to go for innovation. 1.4 billion people, population is like about 20 times the size of anything you would find in a European country, and so to be able to be in this market, to be able to talk to the innovators here, it's been mind-opening.
Thank you so much. Thank you.
All right, I think the GBIP program is very efficient in terms of organizing all the important stakeholders in the industry, the academic, the healthcare, clinical setting. It will be very difficult to achieve if you're a startup. You could probably meet all the stakeholders, but it will take 6 months to do it. So I think it's a very intensive, high-density kind of workshop. And so I really appreciate the opportunity, and it really got me to understand the market, the opportunity, kind of the manufacturers, and the different landscape here in India.
Meeting people face to face, discussing science and business is a big advantage in a wonderful setting, and getting to know people's work in detail is a way of finding points in common, synergisms perhaps, and hopefully potential collaborations.
Thank you so much, sir. Thank you so much.
Hello, I'm Ian Miller from Presymptom Health, CEO of Presymptom Health. We're here in this Global Business Innovation Program mission, AMR mission, to Bangalore and Hyderabad. And for us, this has been an excellent opportunity to meet with a lot of promising Indian SMEs and startups, and also with Indian academic and research centres to learn about their work and explore the opportunities for collaboration. I would say in the several days we've been here, we've already had many very interesting conversations and anticipate having many follow-up exchanges with several companies, and hopefully define some projects we can do together to develop our products together. So it's been very exciting. It's been great to be here.
Thank you so much, sir. Thank you so much.
Hello, I'm Will from Phytoceutical, and we're here on the UK AMR GBIP. I think the incredible thing about coming to India is just seeing the amount of innovation that's happening in India, also the facilities and the acceleration that's happening. And actually, it's inspiring to come and see how we can collaborate in India with some of our technologies together to produce things to help address AMR in the future, not just in India, but across the world.
Yes. Hello. This is my second GBIP, and the reason the GBIPs have proved valuable is it gives you a very condensed snapshot of the technologies that are around, and also how your technology can be used by different startups as well as well-established companies. My company does bacterial and clinical yeast identification, and that is important for clinics, and giving the opportunity, the GBIP gives the opportunity to meet a large number of clinicians in perhaps 3 or 4 days, which you would not be able to do unless it was part of a program such as the GBIP. Thank you.
Hi, I'm Nathan Cox from Folium Science. At Folium Science, we use CRISPR-Cas activities in bacteria and microbiomes to modulate those microbiomes. We're currently working on a product that will launch in Brazil next year to reduce salmonella in poultry and increase their bird weights. We are also using the same systems we have in vivo to produce rapid, portable, lateral flow-based biosensors that are CRISPR-Cas based. And participating in GBIP has been useful for us to kind of assess a new market and to figure out if the market would tolerate our GM probiotics, and it seems like depending on the efficacy and safety, it possibly would, and so that's useful. And then also been interesting discussing the diagnostic market, both with potential partners and manufacturers.
Hi, I'm Sam Whitehouse. I am CEO of Litox. We make light-activated drugs for the treatment of oral cancer and the treatment of bacterial infection in wounds. We're here in India on the GBIP mission with Innovate UK, visiting Bangalore and the C Camp at the moment. We're looking for partners, we're looking for interesting science that we can collaborate on, investment and clinical use here. And we've been coming to India. This is probably our largest market. We've been coming here for a number of years. India has one of the highest incidences of oral cancer in the world, so this is why we think we have to be here in country, doing our market research from there. Thank you.
Hi, my name's Doug Roberts. I am the CSO of Aribogen, which is a synthetic biology company that is spun out from the University of Warwick. The GBIP's been an amazing experience for us, as we've never really had any opportunity to engage with researchers in India, and we've been able to visit a huge number of sites, meet a lot of young and more established companies to talk about our science, and find different ways that it can help other people doing their own research, and hopefully find some new partnerships where we can start to apply our research to new problems. No worries.
Am I clear? Hello everyone, I'm Praveen Kumar Kaveri, Chief Scientific Officer, Chexel Limited. Chexel is a rapid microbial diagnostic company. We work primarily on antimicrobial resistance, and I'm more passionate to work on the antimicrobial resistant diagnostics, especially phenotypic test. CCAMP is one of the globally renowned center for antimicrobial resistance. I'm very happy to be here and very happy to see a lot of people working in the antimicrobial resistant diagnostics. And through this GBIP program, we got a chance to meet a lot of scientists, innovators, academicians, clinicians, and finally we are at the CCAMP. It was so wonderful interacting with people, and we got a lot of insights regarding antimicrobial resistance, and also we got connected with a lot of partners. So very thankful for CCAMP for organizing this. Thank you. Thank you so much, sir. Yeah.
Yep. Hi, I'm Noah Tattersall from Cytocom. I'm here at CCAMP as part of the GBIP visit to India. This whole week we've been able to visit many sites and see different people and see how we can work with them to fight AMR, and also what other people are doing in the fight against AMR.
Hello, my name is Professor Andrew Shaw. I'm the Chief Executive and founder of Atomarker Limited, and we have invented a platform technology that's a plasmonic platform which measures the absolute mass of molecules in a small sample of liquid from the blood. I can measure 10 biomarkers simultaneously in under a minute from a single drop of blood. That means we can measure quickly a patient profile. Do they have a bacterial infection? Do they have a viral infection? Do they have a co-infection? And then do they need antibiotics? The data go into the cloud. So if I can do this everywhere and anywhere in India, in all four corners of India, the data can be collected. And then in good shape to do things like pandemic monitoring and the evolution of epidemics around a particular outbreak. So we have a unified technology that's very flexible. Many chips can be made really quickly. And we're here in India looking to manufacture it efficiently for all of India.
What are the benefits and advantages like participating in
So the reason for joining the GPEP delegation was because I get to come to India. I want to look at setting up an Indian partner to manufacture my device. I've got to meet the ecosystems in India around antimicrobial resistance, especially here at CCAMP. And I think we can collaborate with people that manufacture the device, and they can manufacture the device cheaply, as well as reagents for me. So the Indian ecosystem is very powerful for accelerating the technology.
Thank you so much, sir.
Hi, I'm Dr. Simon Holland, CEO of Barefoot Lightning. We're a UK company that works in low and middle income countries, and we work on animal health and nutrition. And we've come on this GBIP really to try and meet like-minded companies to work in the animal health and antimicrobial resistance space. What we've seen is there is honestly an incredible diversity of companies that I could never have believed before coming. All of these different groups, they offer so much synergy for us that we can see a roadmap to deliver so many more benefits to so many more people. So if you get a chance, do not miss it. I'm a little bit exhausted after the run because I've met so many companies, but that's not a bad thing. Okay, thank you.
Thank you so much.
Hi, this is Ritu from RX Proplint. We are an ecosystems developer doing a lot of initiatives in India. And this event by FICCI and Invest UK is, I would say, a beacon for the direction in which global healthcare is going. There's a lot of inter-border, international, I would say, efforts that go into finding real solutions. And it's been an eye-opener. Lots of young companies doing a lot of great innovation. And I would say there's so much of partnership that we can explore with these companies. So wonderful welcoming the delegation from the UK, and yes, it was a lovely experience. And we look forward to a lot more of this because there's a lot of potential for India as a great partner. Thank you.
You just prompt me. Hi, my name is Ganesh, and I'm co-founder of Trana Lab with Dr. Nitin Deshpande. We are a startup in Bangalore. It's great attending this event, co-hosted by CCAMP, FICCI, and Innovate UK. Wonderful platform to meet several people, large companies from the UK as well as India. It's very important that these things happen quite often. Number one, Bangalore being the hotbed of biotech activities. Number two, we need to build an ecosystem, not just locally, but across the globe. So I believe the Indo-UK events like this will foster far more meaningful and wider interactions in the future too. And I wish everyone all the very best. Thank you.
Thank you very much.
Hello, my name is Mayas, and I'm from the Foundation for Neglected Research, FNDR for short. We are a Bangalore-based nonprofit focused on infectious disease drug discovery, development of diagnostics and devices. I would thank CCAMP and FICCI for organizing today's event. It was wonderful meeting different companies from the UK who represent a variety of fields in AMR. And I'm sure all the conversations I've had today will lead to multiple collaborations down the line. Thank you very much, and best of luck.
I'm Dr. Sudarshan. I represent an organization called Cancer Technologies and Rangadore Memorial Hospital. Today we had an amazing day where there's a collaboration with UK delegates. Was fantastic. So as I'm from a hospital, we are looking for rapid diagnosis. And today I find a lot of solution for rapid diagnosis of AMR. I really want to thank CCAMP for arranging this kind of event. It's really going to help the clinicians and as well as a lot of hospitals to combat AMR. So thank you, CCAMP, and appreciate. Hopefully you will have this kind of events in the future. Definitely going to change the way we look at AMR, and is really going to help the country. So FICCI also is one of the unit that has every clinicians and as well as innovators to get in and enroll. I think they have amazing features in their website. I think I would recommend most of the innovators and the clinicians and industry to get and be partners with FICCI. Thank you.
Yeah, I am Dr. Subhashini, Director of Aristogen Biosciences.
I am Sudha, Director of Aristogen Biosciences Private Limited.
Today's event was very informative in the beginning, and also we could meet many of the UK company who had some synergistic applications for our kind of work. We work in AMR in the way of developing bacteriophage therapy. So we met companies who have some products which are synergistic with our role, And I'm sure this will develop, or we will have probably joint work where we use their diagnostics and our therapy, which will go hand in hand. It was indeed a wonderful organization by CCAM. Thank you so much.
Yeah, thank you, and special thanks to Vicky also. Mr. Ashwin has connected us pretty well, and thanks a lot for this.
So shall I say where I am then? Hi, it's Phil Packer from Innovate UK. I'm currently at C-Camp in India, where we've brought 15 companies here, and they're meeting lots of companies from India to try and develop ideas together to work to produce new solutions, which will hopefully address the silent pandemic of AMR.
Thank you so much, sir. Sir.
Hi, I'm Taslim Arif Sayed, Director and CEO at CCAM. Today we are delighted to host the Indo-UK AMR workshop, where we have a fantastic gathering of different stakeholders of AMR from India and UK. The UK delegation, led by Innovate UK, has brought some fantastic startups working in therapeutics, diagnostics, agri, and environmental health of AMR. And the similar set is being brought out by CCAM in the same fields as well. And the whole day we had some great experts coming and talking about AMR. There was engaging aspects of how the innovators can collaborate, and more so how at the national level India and UK can come together and build collaborative efforts to address this global health issue of AMR. We are hoping to have more partnerships like this, and we are inviting other stakeholders from India, UK, and other countries to come and join us at CCAM to build it together. Thank you. This program was fantastic to begin with, to also have a collaboration with FICCI, which is an industry association partner for this event. That makes it more engaging with the local ecosystem, as well as provide us the global view. And we are delighted to have this partnership, and looking forward to build more on that.
Hi, good evening. I'm Dr. Prabhu. I'm from Director of Hybrinomics Life Science and Diagnostics. We run an advanced diagnostic laboratory and an R&D which caters both bioinformatics and robotics. Here I'd first like to thank FICCI and CCAM to give me an opportunity to come and visit the place here. We had interactions with various UK firms like Lightox, Sexal. These all had given us insights on how new novel technologies have been innovated and used for the further development of science. And this also gives us insights on how we could also develop here and also further collaborate with them for further R&D, as well as in terms of business perspective. Thank you.
I know you people are exhausted. Can I smile?